for today. Today, we actually have a very important and crucial conversations that will be happening. Today, we come together to explore the convergence of healthcare and technology, and where innovation has the power to transform lives, enhance patients' care, and drive investments in rapidly evolving sector. I'm guessing everyone seated here in the room really agrees with that and knows how important these conversations are. Before we dive into the world of health tech, I would like to start by acknowledging some of our partners that made this event really a success. I'd like to start with the Novartis Foundation. We have the Global Fund, we have Patrick J. McGovern Foundation, we have Norscan, Bridge for Billions, and Village Reach. We also do have numerous other partners who have supported us in different ways, and I'd like us to show them an appreciation with a round of a warm hand clap. Thank you all. The mission of this summit is very clear. One, to catalyze investment in innovation health tech solutions, to catalyze collaboration between startups, government, and all stakeholders involved, to create a platform where we share knowledge and explore groundbreaking ideas, which is more or less what is happening in this room in the morning when everyone was coming in, saying hi, getting to know as well as a network with one another. We're connecting pioneers in the industry, not only in Rwanda or within the continent, but globally, which is a very beautiful thing. And importantly, to seize the immense opportunities that lie within the sector as we also unlock the investment opportunities. Throughout the day, as well as tomorrow, we have amazing conversations that are lined up. We're going to have presentations, we're going to have panel discussions, and as well as workshops. But please, be ready to engage, because it's not all about the conversations that will be happening here on stage, but we want to hear from you. We want to hear from you, the investors, the innovators, the dreamers. You know, it's about collaboration as well as connecting. So I hope you're all ready to have an amazing day. And to start us off, help me welcome Dr. Anne Ertz, the head of Novartis Foundation, who's going to deliver the welcome remarks. A round of applause.
Thank you so much for the nice introduction. And I think we had some slides. There's a clicker here, yeah? Okay, that's me. So it's my great pleasure to welcome you here today in the HealthTech Investor Summit 2023, the second day, but most important day, maybe or maybe not. It's really a pleasure to be back here in Kigali as well, in this hub, which is the largest space for innovation on the African continent. So enjoy and take a moment to see how nice this whole Norscan East Africa house is as well. But why are we here? We are here because the challenges we face nowadays are just unprecedented. We have this unfinished agenda of infectious diseases, mother and child health issues, but also the constant threat of new emerging diseases. And at the same time, a rising burden of chronic diseases, non-communicable diseases, such as cardiovascular disease, which is the leading cause of death in the world, also in Africa, in many, many places. And at the same time, we see a rapidly aging population, but also a rapidly growing population. Here, that goes together with urbanization, often very chaotically planned or not planned at all. And most of that urbanization and population growth is happening on the African continent. So we have to do things differently if we want to address these health challenges for all the populations living on the continent. We need to find a new way, not only to deliver healthcare, but also a new way to address health over an entire life course, to keep people healthier longer. And that is why we come to the HealthTech Hub. At the Novartis Foundation, in a nutshell, we use data, technology, and advanced analytics to improve population health while narrowing health inequities. And our work is anchored in the legacy of cardiovascular population health models we have pioneered across the southern continents, called Cardio for Cities. We now bring that to the next level, where with AI for healthy cities, working with data-rich environments to understand what truly drives cardiovascular health outcomes. And all of that work of the Novartis Foundation is underpinned by HealthTech innovations. And the HealthTech Hub Africa here is the best example for that necessary innovation across all aspects of health and care. So the cardiovascular population health approach we pioneered across Latin America, in Brazil, in Africa we were in Dakar, and in Asia we were in Ulaanbaatar and Ho Chi Minh City. We managed with a very simple approach to have a very fast response and a very impressive result. In 1 year of implementation, we tripled blood pressure control rates. High blood pressure, in fact, is the prime risk factor for cardiovascular disease. So that's the first thing we should control better if we want to decrease cardiovascular disability and death. So that model has now been spun off of the Novartis Foundation in the Cardio for Cities Accelerator, which aims to replicate it across many more cities in the world. We aim to replicate it in 30 cities within 3 years. A very ambitious goal, but we need a lot of innovation for that as well. Our own initiative that we drive further, the AI for healthy cities, is running, as I said, in data-rich environments, ranging from New York to Singapore to several European cities, Helsinki, Switzerland's cities, and Lisbon. And there we work together with the city authorities to combine the data from the health sector with data from health influencing sectors to better understand what truly drives population health. Because we know only 20% of our health is determined by the health care we access. The other 80%, we don't really understand what drives those. We know it's linked to the conditions in which we live, we grow up, and we age, but we don't know what is the best or the worst combination of those conditions. And that's what we want to find out in partnership with Microsoft AI for Health, of whom Bill Weeks is here in the audience with us today as well, the head of Microsoft AI for Health, is helping us tremendously with this initiative. And lastly, what underpins that work towards improving population health and narrowing health inequities is really the HealthTech Hub here in Africa. The HealthTech Hub serves two goals. First and foremost, we want to help local entrepreneurs further develop their local solutions to local problems. That is how we see the future for innovating health and care and innovating healthy longevity across the African continent. On the other hand, we also help governments to fast-track such innovations into their public health systems, because it doesn't work to only access part of the population, where most of the population comes to public health systems. You also need these innovations within the public systems. And that is what we do with our blueprints for fast-tracking health tech innovations in public health systems in Africa, pioneered by the governments of Rwanda and Senegal, and now joined by governments of 7 or 8 other countries in the last summit that happened in Dakar. So that HealthTech Hub you are experiencing here today has been a tremendous success. And little did I know when we launched this in 2021 how this partnership would become such a strong and impactful partnership. I want to thank again our anchor partners of the Norscom Foundation, the Global Fund, and the Patrick J. McGovern Foundation to have that trust with us from the beginning and to drive this forward. Here on the slide, you see all our partners nowadays. You have, again, champions of the Rwandese government, the Ministry of Health and the Ministry of IT, also RBC, same accounts for the governments of Senegal and now many other players. But then you see the Blueprint Initiative, for example, is funded in part also by the African Development Bank and supported by Africa CDC, so that it becomes a blueprint for the entire continent. all of our implementing partners, without them we wouldn't be nowhere. So Bridge for Billions, our new partners, Village Reach, and VC4A, the Impact Hub here in Kigali and in Dakar, thank you for being such great partners. And I don't want to mention all our in-kind support partners. You see them on the slide. I would miss some if I start mentioning, so please have a good look. And thank you again for all of that. Without you, we wouldn't have been able to make this hub so impactful. And that is also what has been recognized now a few weeks ago in New York, when we were in New York and we received the P3 award of the US Department of State for most impactful. I cannot move the slide. Can you move the slide? The P3 award for the most impactful public-private partnership. A sign of how the world really sees that this hub here, this partnership here, is making a tremendous impact to many people around the world. And that was such an honor to receive that award in the name of the HealthTech Hub and the entire partnership. So let me end by giving you some numbers. Next slide, please. Giving you some numbers of what the impact has been of the HealthTech Hub Africa in 1.5 years, because it's only the half year for 23 numbers we have here. We all of the entrepreneurs managed to reach almost 3 million people, create 800 new jobs in Africa, and achieve extra 18 million of investments. To all of you investors in the room, I urge you, and I hope you will do this, you will double this number today. Please do so when you hear about all the fantastic solutions that are housed here in the hub. And lastly, we have a beautiful video of the hub to end this opening. But again, welcome, and I hope you have a lot of fun and you make a lot of new partners with all our entrepreneurs to make sure they can get to many more people with their fantastic solutions. Thank you.
Africa represents 22% of the global disease burden, yet only 3% of the world's health workforce. Technology and innovation holds promise for addressing some of the most urgent health challenges across the African continent. Africa is home to exceptional entrepreneurs, many of whom are developing health tech solutions with great potential for impact. Yet many face barriers in securing funding and working with governments to scale the solutions in public health systems. The HealthTech Hub Africa was founded to help governments and startups collaborate on data and technology-enabled innovations that strengthen African health systems. The Hub is unique in its dual mission, focused on meeting the needs of both entrepreneurs and governments as they collectively work to advance health equity.
Welcome to the HealthTech Hub Africa. The HealthTech Hub Africa is more than just an accelerator, and it's more than just a physical space in Kigali, Rwanda.
Since 2022, the HealthTech Hub Africa has supported 68 organizations across 17 African countries, working on critical issues from cardiovascular disease to breast cancer to data and digital systems to strengthen healthcare delivery.
Since I joined HealthTech program, we have been exposed to a marketplace. We got a partnership with another international organization, and also we were mentored. In that period, it helped us to build our business, which increased our users and also increased our revenues.
We are able to access mentorship, quality mentorship, to be market ready as we were just starting. And we were also able to learn about the challenges and the trends in the African healthcare industry.
It allows us to connect directly with innovators from Rwanda, but also from across the continent. It's very important for us to be able to have direct view on the biggest barriers, the biggest challenges that they are facing, by the experiences, hear from them in terms of why they would hope government Rwanda in particular to be a bit more less. And so we take that information and use that to then advise the government on what they need to do in terms of addressing those policy barriers.
For true impact, technologists and governments must work hand in hand in meaningful partnership. We know that those who sit closest to the health challenges are best positioned to help address them, which underscores the importance of supporting local entrepreneurs who are creating local solutions for local challenges. Yet we also know that without scale and support, these entrepreneurs and their solutions will not have the impact on health systems and people we know they can. Governments have a critical role to play in accelerating both development and adoption of new technologies that can revolutionize healthcare delivery. The HealthTech Hub Africa is unique in dually addressing both the needs of governments and of entrepreneurs. And our work is just beginning. This partnership is growing rapidly, with African organizations and institutions around the world coming together to support entrepreneurs and government partners in scaling innovations with the potential to improve health and well-being for millions across the African continent.
Indeed, the HealthTech Hub is at the heart of development when you look at advancing health technology within the African continent. And Dr. Anne, I'd like to thank you for your remarks as well as highlighting some of the important work that is really being done. And you've touched on really the need to find new ways of addressing healthcare challenges. And that is really what the Novartis Foundation is doing alongside its partners, helping startups deliver more impactful health tech innovations driven by data and generating evidence of how they decrease health inequalities within the continent as well as beyond. Now we're going to hear remarks from our keynote speaker for today. Help me welcome Dr. John Baptiste Muranga, President of the Rwanda Medical Association and founder member and treasurer of the African Neonatal Association. A round of applause.
Hello. Hi, good morning. I am not sure what to say for such a gathering of innovators, investors, and all kind that are more versed with the with what we're talking about of the digital health. So as a clinician, you may understand how much my knowledge and extent to this subject is. Nonetheless, I appreciate the invitation of the organizers, and I'm privileged and honored to be here. I am in the position of being the president of Rwanda Medical Association. I am in the position to speak in terms of a clinician. So, and I hope by the end of the day, at the end of the presentation, you will understand the challenges that the clinician perspective holds. And definitely, that's why I think all of you are here, is to bridge the gap of the service delivery from the clinician to the population, to the community that is designed to provide that. So that is, we can go back. I hope this will work. I don't think I have really a very formalized and authenticated presentation, but that is generally what I'm going to highlight about. And every slide is really to highlight an example, but also try to connect whether that example connects and really provides solution both for healthcare systems, but also to the community. So as you may see, really there is a definition. I'm sure everybody knows the WHO Global Strategy on Digital Health 2020-2025. And whatever we do is try to provide the government with a platform to engage and try to really create a standardized approach to providing digital health solutions in one way or the other. And it cannot be more from the previous presenter. That's one of key examples that really we hope can leverage on the existing challenges. And therefore, that covers a broad and specific terminology, but from the health information systems at the government level to e-health solutions, applications, and all the digital solutions that are available. But also goes back to the extent that we don't know for how much and how long will the artificial intelligence impact our clinical services and how we deliver clinical services. So the introduction really creates a broad range of solutions and creates a broad range of suggestions for each one of you seated here that you can find a position in, whether you are an innovator, whether you are a healthcare service provider that is looking for the most possible solution that suits your service delivery mechanism. And therefore, the whole idea would be, is really the solution being suggested, the solution being invested in, is it reducing the inequity? We have heard from the video the issue of quality, inequity, and those aspects that comes back now and forth in our engagements, in our trying to find solutions for health sector services delivery. But also, sincerely speaking, as we know very well, still there are challenges which I'll talk about a bit later. What really does that mean that the innovation will bridge the hard-to-reach community of the society? And then will it bridge the gap between the cities, the services available in bigger cities and those that are hard-to-reach communities? So we need, to the end of the day, how does this, what we are discussing, will impact on the universal health access that is being thrown all the time? And government of Rwanda, you have had good examples of where that I will talk about that, has really tried itself to position and provide the necessary facilitation and platform for innovators and all the investors alike so that we can develop impactful solutions. Other clinicians that I mentioned, the systems cross-cut all aspects of healthcare deliveries. I see colleagues of doctors here seated, but even those that are not doctors, the healthcare system is one of the complex systems that you can think of. It's not one shoes that fits everybody, but rather it is a complex health system. And that's why sometimes the challenges become surmounted, because you need to connect every dot, and the person looking for services in a healthcare systems needs to navigate all those services. We're talking about laboratory. I'm not sure if the pointer works, but you can see it. We're talking about laboratory. We're talking about records. The many questions, annoying questions that we ask for those who have been in a hospital healthcare system of recent. Everybody knows that we ask so many annoying, confidential questions all the time, and people really get frustrated and get annoyed of us until we come to the whole cycle of the system, the ecosystem that we are talking about. So it's complex, and whatever solution we are talking about is to navigate and see how that complex system can be made easy and can be easily accessible. Definitely, most of what I'm going to say is not new to many of you, because this is what you do every day. What I do every day is to treat patients. I'll tell you that the disadvantage of what we need to break is that I treat patients as they were treated 50 years ago. Despite that there has been this sprawling of the technology and all that, but I can tell you my patient still has to book. Sometimes there is no system to give that patient a feedback that my clinic has cancelled. Some will travel, come to the hospital to be told that your clinic is cancelled. Go back and come back another day. Nonetheless, I will still write a piece of paper and request for investigations. The patient will still have to go line up, pay, and then after paying, it goes to the phlebotomist, the person who takes the patient's blood, takes blood, sends to blood. After all that, I would ask the patient to come back for results after a couple of days. In other words, I'm doing medicine as it was being done 50 years ago, despite that we are discussing how rapidly we are growing. So it's not saying that we are not doing enough. It's just that we need to move faster for those who can. Okay? And therefore, that's what we purport to be the advantages: enhanced personal health and life quality. I will see lots of that you have presented of the solutions that are being provided, including digital wearables. But we'll talk about, if I get access to it, does it mean that the most fat-rich patient will get that digital wearables? Does it charged by solar? Does it charged by electricity that the most difficult-to-reach patient may not have the access to that electricity? So it's all that navigation services we're talking about. Okay. And then we talk about improved access to healthcare services. I mentioned about the challenge that we are still doing the same way, less waiting time. Anybody who has visited King Faisal Hospital of recent in the last 3 months? What was the complaint? Somebody's waving. How was your experience? You are visiting, but I'm sorry, yes, I know. I'm teasing. But what I'm saying is that we get feedback from patients every day. And the feedback is how long it takes for them to get the services. And all the time, it's discussed, and so I'm saying we are not yet there. We are not yet where we can break the chain of long waiting times at our health facilities. We are talking about more autonomous management. What we mean by autonomous is that you have all the information, you have all the data about yourself, and you can decide. You can make decisions based on well-informed information that you get exposed to. And that is not just the healthcare system. It's still the government. There are a number of opportunities, and definitely that's why they mentioned that the government are taking lead in investing. Every government now, more or less, you will inform me, has strategies to really enhance and encourage and provide platforms for innovation and technology in terms of health, digitalizing the healthcare system. And we talk about the same that you may have mentioned, reduce pollution and energy consumption, because all the activities that I mentioned contribute in one way or the other into polluting our environment, and therefore with environmental degradation that we're talking about. Definitely, if you are talking about most of the least developed countries, including Sub-Saharan Africa, including Rwanda, we are struggling with shortage of healthcare workforce at all levels. And therefore, we are looking for solutions where that can be, at least use the few that we have the most effective way and be able to do that. And the most take-home message for any government is, are the citizens, the community, are they really happy with the services that they get? And we are looking into that. I will not delay into this because there are NGOs here that should speak more into that. But what I think for me is really to call up that the investment by NGOs should be aligned with the government, should be aligned by companies like Novartis and others that are here. It's that alignment that I am sure, in my limited understanding of this complex subject, that will really create really durable, sustainable, and accessible solutions. But if everybody works in silo, then we are most likely have another 20 years of time when we have not achieved most of the goals that we're talking about. And I will not delay with this. This is all I got from online, so nothing scientific, the approach that I'm talking about here. But I'm saying that Rwanda, we are not doing the best, despite the solutions are. We are trying, and really all of us seated here knows that the government is doing all it can to position itself as the digital, and to create a health sector digital transformation. So they are investing, they are collaborating, they are engaging partners in many ways to create that solution become a real part of the healthcare system, delivery system. Nonetheless, the there is still gap in many ways, as we saw, that needs to be bridged, and everybody here has an opportunity to play a role if wish to. Definitely a few may or some may not know, but I can tell you as a clinician, we had no choice but to adapt to this digital solution during the COVID, where getting in contact with the patient was not possible, and we saw that it's possible. The take-home message for this slide is that COVID showed that it's possible, because we were able to reach, we were able to communicate to patients, we were able to track and monitor patients without going to their homes. And that was done effectively. The Ministry of Health was able to map the high-end zone and be able to zero in by using the geographic information systems and using trackers. So it was possible. And therefore, what we're talking about is something that is not really that is out of touch. It's something that can be possible. It's something that can be built and constructed. This one, again, many of you know, but I wanted to highlight that it's all at all fronts of healthcare system. At the central level, this has been a period of Ministry of Health's health system strengthening. And I can tell you that it has changed a lot of how we do business. For example, if I may use the word, the laboratory information systems. You can't tell from whichever district, whichever hospital, what is being done and what is possible to be done. From the logistics management information system, ERMIS, we can procure, the district hospitals can submit their needs, their gaps by looking on anticipation, and the central government can tell where the challenges is, where they are running out of critical items, and they can still be navigate and anticipate to do that. It's not efficient yet, but those are central government initiatives that have managed to strengthen the basic principles of health systems that we have in Rwanda. And again, you will meet some of these people, but I mentioned because that's what we're talking about. These are some of the pioneers in Rwanda that we know have tried to really change the way we do things. Again, the comment is that much as they are there, their level of scale-up, their level of being nationalized is still very limited. And the question here is that we need to discuss in such a forum, is the scaling up, being the potential to scale up and have everybody accessible to such solutions. But otherwise, these are real products that are there. And I will mention you have had the zipline. It's been in years in doing that, and it has changed the way we provide especially blood products to the population. Yeah, you can imagine it used to be a nightmare to drive 2 hours, 3 hours to come and pick 2 or 3 pinch of blood and take them wherever they are supposed to do, and now it can be done. So this has been part of the Ministry of Health's effort, and it has worked. We have seen it, that it has changed the way things can be done. I am not going to stay. I saw that they are representatives from different countries, but again, just to highlight, that was part of my presentation to bring to the fore to the audience that there are solutions in different countries. My take-home message is that what do we learn from each, and how do we, instead of duplicating many, build on one successful and then scale it up to provide the solutions that are provided. For example, this is a South African startup solution, digital solution, that reduced. I liked this because what I wanted to say is that missed appointments decreased by 30% to 4%. And that's very important. The reason this may seem very simple, but it works, it impacts the use of the clinician that is in the hospital to wait for patients that will not come. It helps to predict in the next and planning on how we do our health services, and very. So these numbers may seem very small, but if it is working in a health sector, they impact a much. If you take the numbers and conceptualize and see how they impact the service delivery and using the few resources, both human and non-human resources we have, then all that can create quite robust solutions. The same, we're talking about telemedicine. I'm not sure if somebody will talk into telemedicine, but I can call you that there is a potential to really transform the telemedicine. What am I talking about? We still require somebody with hypertension to always travel to the hospital to give the list of blood pressure is taken for a whole month to the doctor to say, oh yes, it's stable. It's been stable, so you're doing well, and then write a prescription. This can be done. We don't need really that person to no longer come with the current digital options, with the technology that we have. We should be able to track these people, talk to them, help them send whatever the information they measure from their measurement, and then we decide. We tell them that you're doing okay, you can continue your work or change ABCD. But this is very important. But it's not only that. As we sit here, we know the challenge that most of our low-care health centers are managed by the most junior, skilled workforce. Then we can support them. We can educate them. We can mentor them. Somebody talked about mentorship. But it is not yet a reality. As I speak now, in Rwanda, we are not able to do that at a certain extent. It's still located on few initiatives, but these are things that can be done. The telemedicine can be done in a more efficient way and completely change the way we do business in healthcare system and allow the population to enjoy their life as well as receive the most possible care. The same applies to improve community health by increasing access to health information. Absolutely, there are challenges. We have one of the robust network of community health workers in the region. You may have heard about that. And we are trying to use them. They do help us. They have created a backbone of health service delivery at the community level. How can we continue to educate? How can we continue to empower them? How can we transform them from the members of the community that we trained to the actual really well-versed, knowledgeable part of community health system, part of the healthcare system. So there is a number of things. Majority of them have access to the phone, so we can educate and empower them. I will not talk much about, again, the SEM, because she just mentioned a very important aspect approach to non-communicable diseases. I think this is not working. Is it dying? Yes. Okay. Yes, I was pointing to the wrong direction. Sorry about that. This is what I literally said. This is when you come to us. This is what you go through. But I won't talk about that. I'm not sure how many people can see. But this is what you have to go through. That's okay. I was just showing. Yeah, thank you. So I was showing the whole ecosystem where a patient comes, goes, and then gets out. So this is typical of what you would say. I'm not sure how many hospitals, but my hospital, you do more or less that. And therefore, and I will assure you, it's not the worst in the country or in the region. But I'm saying we are still doing the same challenges. And therefore, the consumer health apps that you mentioned, the digital therapeutics that we'll talk about, validated variable that the biomarkers that we are talking about, they should be able to help us bridge the gap that I'm showing there. They should cut a few of the parts in that complex chain of patient journey in the system and be able to easily navigate and have accessible health solutions. And this is all. Many of you are developed by some of you that are seated here. But I will mention something very important. The truth is that we are having more disconnected solutions. And they have two challenges. One, I will not cope up with them as a clinician. Sincerely speaking, given that the work that I do, getting used to 10 apps that are measuring blood pressure or other that are doing it's going to be done. So what I need to challenge the audience is, can we really align to more validated tools and try to scale them up if we really believe in them so that we try to come up with few, of course few, I don't know the number, but I'm saying few that are able to be scaled up and provide the solution without burdening the health worker force and the few health workers again that we have. So to cope up. Appreciate it. So I will discuss, I go that because of time, those you discussed, yes, I'm almost going to the next stress. The scientific evidence, you have done that. I was looking into that. It's really emerging. It's becoming a lot, and we should catch up with what those that have the evidence, so especially the best residents. So this is my last slide that I need to discuss, is the challenges that exist from the clinical perspective. Disconnect between health workers and the rapidly evolving digital health solutions and tools. There's definitely no strategy on how we train our health workforce to match and adapt with the solutions that are coming up. Sustainability scale-up, I mentioned it several times, and the cost and accessibility. Is it really accessible by everybody? Is it going to be a solution for everybody at everywhere? That's going to be a challenge that we need to discuss. And lastly, I mentioned about comprehensive rather than disintegrated solutions that will create the solution. So with that, I think that is key challenges that I wish that the teams, people here will discuss, and at the end of this symposium that we are able to provide solution and recommendation that are applicable. Thank you, and thank you for taking a few of your minutes. I appreciate your time.
Thank you so much, Dr. John. Definitely a lot to unpack and a lot to look forward to in the next coming sessions. We're now going to get our next speaker who will be giving a presentation on the underlying gaps in the investment landscape within the health innovation space. Help me welcome Wilfred Njagi, investor and CEO of Vilgro Africa.
Thank you so much. Bonjour, mulaho. That's the first word I learned today about how you greet in Kinyarwanda. This is my first time in the HealthTech Hub. Thanks to the invitation by Lucy, I'm very excited to be here. I'm a co-founder, CEO of Vilgro Africa. We run an incubation program out of Nairobi, working with startups across East Africa. And really why we are here is in the spirit of partnership. We are very impressed by what the HealthTech Hub has achieved in the few years. And we are saying, can we do more together? How does this... sorry. So, as I said, we were set up in 2015, about 8 years ago, to work with healthcare startups across Africa. And we normally give two things. We give seed funding and we give technical assistance. And so far we've disbursed $2.7 million and our startups have unlocked $22 million of follow-on funding. Some of the startups we've worked with also happen to be in the HealthTech Hub, and that's why we think there's a lot we can do together. As you can see on the map there, those are some of the countries that we cover. Something with the, sorry. So I'll be looking briefly at the landscape analysis. Maybe you can help me with the slides. So this report, this landscape came out of a report that was done in 2022, and they looked at where do we have the largest ecosystem concentration? And as you can see on the map, it's all along the edges of the continent. In between, you can see very many blanks if you look at the central part of the continent. And one of the conversations we're having with the HealthTech Hub is, how can we scale what has already worked so that some of these other ecosystems that are underrepresented can also get to benefit. Next slide. And here are some of the healthcare-focused incubators and accelerators. When we started 8 years ago, it was a very lonely space. But now we are so happy that we have more and more players, starting with HealthTech Hub Africa. We have Futurize You, which launched a month ago. We have Innovations in Healthcare out of the Duke University. We have Vilgro. We have Innovations in Healthcare, which is a supply chain focused call. We have Make More Health by Boringa. And these are all places that you can go as a startup to benefit in terms of getting more capital, more technical assistance, And when we come together, what we like to see is the benefits accruing to the startup are increased. Next slide. Now, looking again at 2021, which was a year that was very, very vibrant in terms of funding raised, and we saw a lot of concentration around the top 4 countries, Egypt, Nigeria, South Africa, Kenya, as the big 4. And part of the discussion is how do we now spread this to the rest of the continent? We are 54 countries. I think we should have a lot of activity in the rest of the countries, including Rwanda, which is up and coming. Next slide. So in addition to the top 4 countries that I mentioned, these are the other emerging ecosystems where we saw a lot of funding raised. So if I mention your country here, please shout or say something. We have Ghana. Any Ghanaians? There you go. Senegal. Ivory Coast. By extension, okay. Cameroon, Uganda, Ethiopia, Rwanda, Rwandese in the house, Tunisia, Morocco, Zambia. So these are the other emerging ecosystems where we saw a lot of funding activity happening. One thing I would like you to think about as I go through these slides is the 4 Ps of marketing. Thinking of an investor as your customer, and think about the 4 Ps: the place you're operating in, the product you're building, the pricing, and the positioning. And what we've advised some of our startups, for example, if you're operating in Ethiopia, which you saw is up and is an emerging one, but is still don't see a lot of funding activity. What we've seen is that if you're in Ethiopia, an Ethiopian startup, and you operate in more than one market, you have a new presence in Rwanda or Kenya, it makes your fundraising journey way easier. I don't know whether you've experienced that. So that if you're single country focused, can you start thinking of which of these are the next countries in this emerging frontier can you go and launch, which again will increase your chances. It will also help offset some of the political risks and other risks that we encounter as a continent. Especially in Kenya during election period, like last year, it's barely impossible to do anything. So if you're operating in Kenya and Ethiopia or Kenya, Uganda, you spread your risks. Next slide. Now, people have been talking about 2023, the yellow line, not matching up to the previous 2 years. I think we saw a lot of COVID spike in terms of funding raised in 2021, 2022. And 2023, we are seeing a bit of a winter. And in my next slide, I'm actually arguing it's not a winter. It's actually, maybe go to the next slide. Go back. If you look at this slide, it's not really a winter. We are if you look at the moving average, and 2023 being the last column, it's like we are coming back to the normal average that was there before COVID, which means that we are still doing okay, right? So don't be scared. I feel like a lot of people have been wondering, what are we going to do with this fundraising winter? But what we've seen is that, of course, the market has readjusted beyond the COVID hype. We have valuations now coming down. We had few startups raising at $100 million, $200 million valuations in the last 2 years, but now there's a bit of adjustment, which will be good overall. I think these balances have to be there for the ecosystem to work. So be confident that it's still a good time to be a startup entrepreneur. Next slide. Now, HealthTech, if you look at the Africa ecosystem and you map by sectors, fintech is number 1. We have clean tech and wash number 2, energy and wash and clean energy. We have e-commerce number 3. Then health tech is the 4th one. So we see that health tech has maintained that post-COVID growth and really sustained itself. And I think health tech is the new fintech. Yeah? I don't think anyone is going to put money in another Stripe or in another, which are the other most famous fintech? M-Pesa, Flutterwave. No one was willing to fund another Flutterwave. So I think health is the next fintech. So be prepared. This is the right time. Position yourself, going to the second P, position yourself well, because as Dr. Ann was mentioning, there are a lot of things that need to be done to increase longevity, to increase the health, population health, because as we've learned, without health, it's not worth discussing the other things, right? It's not possible to discuss clean tech, renewable, all these things when you don't have healthcare, right? So the healthcare is going to be the big mover in the coming years. Some of the things we are seeing as drivers include a growing cashless economy, mobile money, so a lot of cashless solutions. And we have solutions like Eden Health, I think here in the room, that are driving on that to build a mobile-based health insurance. We have growth in spending. Africa population, we have the upward mobility. More and more, the middle income is increasing. That means they're going to be buying and seeking more healthcare. We have urbanization, as you saw also from Dr. Han's presentation on their focus on cardio for cities. I think that as urban population grows, we need to start having conversation around how do we take healthcare in the masses, especially the slum and low-income populations within the urban. We have a young population which is savvy. These are people that don't want to go and queue in long lines. They would rather get healthcare at the comfort of their mobile phones. So that's another growth driver. Digital penetration, including the internet connectivity, fiber connectivity. In some of the countries, it's gone up to the villages, right? You can get fiber in the remotest part of the continent, which then helps us to build things like telemedicine and other solutions. We have growth of funding. I think I mentioned that already. And asset investment opportunity. Healthcare is emerging as an asset class that is investable. And I'll show you how some investors have actually made money out of investing in healthcare. Next slide. Now, good news. Here's the good news. Of all the sectors, only one sector grew in Q1 of this year, which is healthcare. As all the sectors were seeing a decline, we still saw a growth, which backs my earlier point that health tech is the next fintech. And the growth drivers I showed you earlier I've attributed to this, right? I think events like this, HealthTech Investor Summit, has also helped bring visibility to the sector. Next slide. So who can you go to when you are building a health tech startup in the continent? These are some of the active players by stage, right? So if you're pre-seed, trying to raise below 100K, we can come here to HealthTech Hub, View Grow Africa, Innovations in Healthcare, and I3. As you go to the next level, you can 100K to $1 million, which you call the missing middle. You can see more players are now coming to that area, which used to be underserved. We have Jazza Rift Ventures, we have Health 54, we have Health Cup, and some of these are people I'm happy to introduce you to out of this conversation. Then as you start to scale, those are the players in the Series A and post-Series A space. We have AIC, we have Transform Health Fund, we have IFA, among others. Now, let's talk about some successes. These are some of the startups that have raised the lion's share funding in the continent. We have Reliance Health, and this is 2022 alone. Reliance Health raised $40 million. We have M-Pharma at $5 million, Good Life $12 million, CarePoint raised $10 million, and Turaco $10 million. That means that there are pace setters ahead of you. I don't know how many here want to raise these numbers. Raise your hand up so that investors can see you. Good. So these are the startups you can go after. Back to mentorship. These are some of the founders you can be talking to get tips on how to raise. We've also had exits. Remember I told you healthcare is an investable class. We've had some acquisitions and exits this year and the last year. Doctora, who knows Doctora in the room? From Nigeria. They were just acquired by a group of hospitals called Evercare. We have M-Pharma, which acquired Faltons and Health Plus the other day. So these are the new trends that, and going back to positioning in the 4 Ps, who is your potential acquirer that will give me an exit as an investor? I think investors in the room would like to see that, right? as you build, let us see which corporate is going to finally acquire you or do a strategic partnership with you. But now coming back to the topic of the day, which was the gaps, I wanted to start with the opportunities first. Now let's go and see what are some of the challenges that we encounter in the ecosystem. One, I think, biggest issue is around gender equity. We saw only companies led by women only captured 22% of deals last year, but that was only 1% of the value. Huge discrepancy there. An interview done, how many female startup founders are in the room? Let's cheer them up, because these are the... I think when you're building health, you have to build it equitably. I think women are the best healthcare seekers. Therefore, we need more women founders actually building solutions for healthcare. Majority of women founders are saying that they are being locked out. 80% of women interviewed by Disrupt, they experience a negative bias just based on gender, nothing else. And we've also seen that there's no one single market in Africa that has more than 23% of its startups being female founded. I think this is a place where we need to pull up our socks to address that gap. The other gap that I see, as I mentioned earlier, is that this over-concentration in the 4 markets, I think, is not good for us. We need to see more activity in these emerging markets that I mentioned earlier, Ghana, Rwanda, Ivory Coast, Uganda, because if you talk about healthcare access in a continent that is soon going to be over 1 billion population, you can't do it in small pockets, 4 pockets. We need to cover the entire in a leave no one behind kind of approach. And these are also additional challenges and opportunities. I try to flip the coin so that each challenge also has an opportunity on the other side. I think one is a fragmented market with different regulatory regimes. We discussed this yesterday, that each country you walk into, you're going to encounter a different regulatory regime. Thanks to the policy blueprint by HTHA, that some of these solutions are going to be solved. The other one that Dr. John mentioned very well is we have fewer and fewer workforce because of medical brain drain. Africa spends taxpayers' money to educate healthcare practitioners, only for them to leave and go serve in Europe and Western markets at no cost to their taxpayers on the other side, right? I think we're being unfair to ourselves. We should create conducive opportunities for healthcare workers here. And HealthTech is one such space where we can do that. I think healthcare financing is another one. Our governments don't like spending on healthcare. Very few countries have met their budget declaration of spending 10% of GDP for healthcare. I think Rwanda is one of them, so we should applaud them. I think they're doing really well. But now, going back to my 4 Ps, what does this tell you about pricing? If you're building a product in HealthTech, it has to be very, very affordable, because people are spending out of pocket, and it's severely underfunded. You have to go affordable price, but mass market, as opposed to high price. The other challenge we see is supply chain. There's a lot of, and during COVID, this became very clear that our supply chains are not in order. We need to have a way of addressing that. I know companies like VBEG, I don't know, is VBEG in the room? They are trying to solve this kind of challenge. Double disease burden, I think Dr. Ann highlighted very well that as our populations are aging, communicable diseases are still there, they haven't gone, and now we have an increase in non-communicable diseases. So I think Africa is going to encounter a huge, huge disease burden. So some of the solutions we are building should help us address that, right? Preventive healthcare like Livestream, which helps us reduce some of these lifestyle diseases, among other solutions. There are big 3 opportunities there, including a growing market. It's projected to be $259 billion in 2030. It's a huge, huge market. We have big data and AI, which if we streamline our regulatory issues and our interoperability, then we can leverage that big data so that whatever has worked in Rwanda can quickly be replicated in other countries quickly. Again, mobile penetration. Anything you try to build, it has to be on mobile. for you to ride on this opportunity. Now, back to our approach to some of these challenges. I think one of the biggest challenges we face is the ecosystem is still nascent in its formative years. And what we've done as ViewGrow is work with all the partners in a triple helix approach. How do we work with academia to make sure that we are teaching medical, the next wave of medical practitioners are being taught in line with now the health tech solutions? How do we partner with the private sector, corporates? How do you partner with government to really build that ecosystem? I think the other challenge is we also find that C-level talent is missing. Sometimes you are so focused on the tech and you leave out the clinical side of things. So we like to see well-rounded teams. If you're a computer scientist, who is a clinician in your team? I think those are some of the things you need to address if you want to raise capital. The other thing is lack of staying power. I think some of the investors, they really want to get in and get out quickly as possible. It's not possible in healthcare. Yesterday we learned about that whole drug development process being a 17-year journey, right? So it's not a place where, as an investor, you put money in and you expect money tomorrow. So as ViewGrow, we try to have a long-term view. We've not exited financially in the last 8 years because we still feel that these companies will take a while, among other challenges. So what's the way forward? I think Dr. John said very well that the donors need to be sitting and speaking with governments. The governments need to be sitting down and speaking with private investors. I haven't seen a situation where if it's a USAID or another, or a Grand Challenges Canada, sits down with private investors, governments, and say, if we put money in this area, this disease area, is it investable down the road by private investors, right? Will there be uptick on the government side? I think those conversations, we need to have those in that continuum. I think that's the first and the second point combined. The other way forward, I think, is, again, I agree with Dr. John that we need to we need to scale what has been proven, as opposed to replicating, doing pilots on the same thing. If you're building a solution, and you realize someone else in Nigeria has already had a head start, how can you start working together so that we don't waste resources? Two of you can come together where 1 + 1 is bigger than 3, and it can help you open market in the new country. You can do vice versa, and you start working together. And for us as investors, we like that we are putting our money and backing the winners as opposed to spreading ourselves too thin. The other thing we need to start doing more as investors is due diligence sharing. I just learned of a deal in TZ the other day that it costed almost $100,000 to do due diligence. And when I heard that, I was like, man, we could have, if we were sharing due diligence, that money should have gone to the startup as opposed to being spent in doing the site visits and all, because we already had done due diligence on that startup. So we just needed to share that information with the investor. And I think that's some of the collaboration we can also start doing with HTHA, where investors, we can invite you in and we share our findings. If you have accelerated a startup for 10 months as HTHA, believe me, they have more insights than you will be able to generate as an investor with a 3 weeks, 4 weeks due diligence, expensive due diligence. So we need to start doing that more and more. And I think I come to the end of my presentation. Thank you so much.
Thank you so much, Wilfred, for that in-depth presentation on the opportunities and challenges of the investment landscape. We're now going to have a health break, about 20 minutes, but when we come back, we're going to dive right into our first panel discussion. We'll get to hear from some of the startups, get to hear the success stories, what they did, and how we can learn also from what they're currently doing. So 20 minutes, let's all meet back here. See you all in a bit. everyone kindly take their seats. We're going to proceed in a moment's time. Being done here. We're very delighted that you could all join us here today, and we also do look forward to the closing remarks that will be delivered by Dr. Lutz Hegemann, President, Global Health and Sustainability at Novartis International, AG, Switzerland. I really hope we'll all be around to really get to hear from the insights as well as the years of experience. So we all have a lot to learn as well as to connect. So I think as we continue with the conversation, I'm going to introduce our panelists who are going to come here, and as they come one by one, a warm round of applause, yeah? Let's just give them the encouragement. The panel will be talking on fast-tracking project success stories from the HealthTech Hub Africa use case grant recipients. The first panelist we have is Peace Ndodi. She is the co-founder and CEO of Livestream Health. A round of applause as Peace comes to the stage. Peace is a visionary healthcare provider and entrepreneur holding a bachelor's degree in human nutrition and dietetics, along with a master's degree in global health delivery. She has a passion for enhancing lives, and Peace's journey really began as a dedicated nutritionist in both public and private healthcare sectors, and these experiences paved the way for her with the transformative entrepreneurial venture as a co-founder of Livestream Health. Our next panelist is Dr. William Mafam, CEO, Vula Mobile. He founded Vula to connect health workers professionals. His personal experience as the vice chair of the Rural Doctors Association and later as a specialist helped form the solution. To date, Vula has over 33,000 registered health workers on the platform. Over 1.4 million patients have benefited to date. William believes in partnerships. That's they're really key to delivering healthcare as well as unlocking the opportunities. Our third panelist is Asteray Lema, Deputy General Manager, We Care Digital Health. He is one of the co-founders and deputy managers of We Care, an Ethiopian digital healthcare platform that enables patients to connect with practitioners for online consultation or in-clinic visits. And he graduated from St. Paul's Hospital Millennium Medical College in 2019 and worked as a general practitioner in remote areas of Ethiopia for 2 years. In 2021, he joined the startup technologies and became part of the co-founding team of WeCare. And our amazing moderator for this panel discussion is none other than Paula Akujizibge. A round of applause as she takes the stage. She is the operational research lead digital health at Find. She has over 15 years of work experience in the health sector, focusing largely on research and implementation. She has a bachelor's of pharmacy and a master's degree in epidemiology and has worked at multiple levels of healthcare, ranging from primary health to global policy formulation. And since 2020, she has managed Find's digital health operational research collaborations with ministries of health, universities, and other partners in African region, spanning over 10 projects and 8 countries. All to you.
Thank you, Fiona. I hope you can all hear me fine. All right, good morning, everyone. Great. Yesterday I came by in the afternoon and asked someone, how has the day been? And they said, it's so interesting, but you know, health people are so quiet. You don't know if they're listening, you don't know if they're tuned out. So I'm glad to hear we're not the quiet people. Let's beat the allegations. I know we've had a lot of speeches today, but now we're getting into a very interactive, you see, he's beating the allegations, thank you. We're getting into the very interactive part of the program. As Fiona has introduced, we have some fantastic panelists here today. We might have to crane to see each other. But it's a great pleasure to be here with you all, and thank you also to HealthTech Hub for hosting this event. It's always very energizing to be in this space. Find has been a partner of HealthTech Hub for about a year now, and it's really great to have these opportunities to interact with people who are at the forefront of visualizing, conceptualizing, and bringing to life some of the most important digital health innovations in the continent today. So thank you very much to the panelists. We're looking forward to a lively conversation, and I think we're going to jump right in. We'll be hearing a lot about your solutions today. We've heard a lot about solutions, the way that digital health offers some answers or some mitigations to many gaps in the health systems. But before we get into the solutions, I'd like us to take a step back and have you tell us about the problem. What is the specific problem within the health system that each of your technologies is trying to address? And when we talk about the problem, I don't want us to talk about institutions and systems, but really to make it a people-centered story. So, for example, Vula, you work with health workers, between health workers. Livestream, WeCare, you connect health workers and patients. For all these beneficiaries, what does the world look like in the absence of your intervention, and how do you help to solve some of the problems in that counterfactual piece? Since you're right next to me, Yaralak, we're going to kick off with you.
Thank you, Paula. Good morning, everyone. I'm excited because this is a problem I enjoy talking about. One thing I learned while starting this journey is that if you don't fall in love with the problem, then you probably won't find a solution. And I'll gladly say that I've been able to fall in love with this problem. So at Livestream, we address the elephant in the room. We've all been talking about it the whole morning, non-communicable diseases. And as you mentioned, what the world looks like without Livestream. Currently in Rwanda, 6 out of 10 mortalities are caused by these diseases. But on the other hand, the healthcare system is still overburdened by communicable diseases. So there are no interventions in place to address this rising burden. But on the other hand, more fast foods, sedentary lifestyle, all of this is growing, but then the healthcare system is not putting in place the necessary interventions to address all those problems that are rising at the moment. And one thing that shocked me during market research is that first, people have no idea, and when I say people, since healthcare is a human right, I think we all believe so. This is the last mile communities. They have no idea what an uncommunicable disease is. But if you mention HIV, if you mention malaria, everyone knows what you're talking about. So we all keep saying awareness, but you don't realize the necessity of awareness until you talk to these people. You'd say, hypertension, and people get to the point where they die and their families think it's witchcraft. They have no idea what this is. And this is something that can be managed with the right interventions. So that's why we won't wait for the current systems we have to intervene. So we can do the awareness part and early diagnostics. People don't have to get to know that they're sick when it's too late. There is a whole very big gap, and Livestream came in to be in that intersection to let people know that these diseases are out here, the risk factors associated to them, and also get access to early diagnostics without going to a hospital.
Thank you very much, Peace. And we'll come back to some of the specific ways in which Livestream is doing that, some really exciting work, having won the challenge last year for cardiovascular interventions in Kigali City. I really liked what you said about if you don't fall in love with the problem, you probably won't find the solution. And I'll add to that something I always say, which is if you don't understand the problem well enough, you will probably become part of the problem. And we'll get back to discussing how exactly you engage with the larger ecosystem that faces these problems. But William, I'd like to come to you. Vula is slightly different now. It's connecting not necessarily between patients and providers, but across different levels of the health system between providers. Can you tell us a bit more about the problem you're solving?
Hello. My name is Dr. Will Mapham, and my passion is improving healthcare in rural areas. And so as soon as I qualified, I went back to work where I'm from in the Eastern Cape. It's where Nelson Mandela's from. We worked in a hospital that was rural. We have to define rural. It was an hour-and-a-half drive to get petrol, so kind of self-defeating. Also an hour-and-a-half drive to get ice cream, if that means something more. But we did the best we can do. There were 3 of us working there, serving a population of about 250,000 people. And when you work in a rural hospital, everyone knows who you are. And so the people that come to the hospital aren't just patients, they're your friends or people that you know. And so I was working very hard, and a patient came in, and he had an eye condition. This is in 2004. And I didn't know what it was. It looked very serious to me as a junior doctor. So I wrote him a letter, and I said, please go to Mthatha. It's our nearest eye clinic. It's only 3 hours away. And I hoped that he would then go and get the help that he needed. 7 years later, I went back, but now as a specialist, and he came with the same letter. He was so excited to see me, with the same letter written 7 years before. But unfortunately, he had gone blind in that eye. And looking at it as a specialist, I realized it was actually a simple condition, had just gone untreated. And worst of all, we even had the medication he needed the first time I had seen him. So I became determined to make sure that that never happened to anyone again. But I didn't understand the problem, as you said, until I worked as a specialist. And if you go into any specialist unit in any hospital, you'll hear a phone ringing. And that phone just rings and rings and rings with rural healthcare workers trying to get advice from specialists. So it was only then that I realized we had to solve the problem at both ends, from the rural healthcare worker or a general healthcare worker, and from the specialist point of view. So we built Vula to asynchronously connect healthcare workers anyway with specialists in their area. So yeah, we've been doing that. We started in ophthalmology, which was where I was comfortable from. But having come from a rural area, we realized it can't just be eye care. It can't be kind of a silo. So it's expanded. Vula is now used in over 75 different specialties. I didn't actually know there were so many specialties. But yeah, excited to share more. Yeah.
Thank you, William. And last but definitely not least, over to you, Astere. Please tell us a bit more about what WeCare is doing in Ethiopia.
So to start with the problem, I would like to go back to what Wilfred said in his previous presentation about brain drain in Africa. So that has been one of the biggest challenges in Ethiopia. So a study done back in the early 2000s found out that there are more doctors in Chicago that are Ethiopian than there are doctors in Ethiopia. So that's, yeah, so the government found out this problem and they came up with a plan, and like most government plans, it was very ingenious. So they came up with this plan to graduate many doctors and to release into the market, so-called flood and retain method. So, but the problem was that the infrastructures were not able to accommodate those newly graduated doctors. So now we have unemployed doctors who are who spent most of their youth life studying medicine and have no other skills other than treating patients. So this has been close to home, as I am one of the doctors of that generation. And after I graduated, I later moved to rural parts of Ethiopia, where I worked for 2 years, which has been quite a great experience. But coming back to the capital, where I grew up in Addis, there was no job to do. So unemployment still a big issue when I came back. So that's when I joined Startup Technologies, and they were already working on a solution. Our founder, Dr. Betel, has already been a mentor to me in med school. That's where I joined her. So that has been one of the driving factors. The other one is still with the high number of unemployed doctors, we still have the lowest doctor to patient ratio in the world. So the WHO recommendation is 1 to 10,000, but we have 1 to 1,000 ratio of doctor to population ratio. So we have to manage a way to bridge this gap. where patients can be treated without using the existing infrastructure. So we have to find a platform that is able to bridge this gap, and thus WeCare was born.
Thank you for that great snapshot. And I think what's clear from all the speakers is, I said problem singular, but actually each of these innovations are addressing multiple problems at different levels, starting with the patient, the health worker, the wider health system. And it's typical, I think, of all digital innovations that you are coming into a much more complex ecosystem. And a single innovation is going to have effects, positive or negative, right, in many different areas. So I'd like to hear, and maybe I'll start with you, William, since you developed and rolled out your innovation in a health system where you have doctors who are already overworked. I think Dr. Jean-Baptiste in his opening statement spoke about how as a single doctor you may have 12 different apps for multiple conditions. You're trying to juggle across all those while dealing with a long queue of patients. And then Vula comes along, and yes, you're providing some solutions to certain problems, but there's a much wider set of challenges that you're having to navigate. Could you tell us a bit about how, in the journey from when you first started to where Vula is now, how you have engaged with government, with Ministry of Health, and also importantly, how you have avoided contributing to this fragmentation of so many different tools for one doctor and one patient? Yeah.
It's a very good question, because when we first started, we kind of set the. You can say if you if you build it, it doesn't mean they will come. And when we first launched Vula, I was so proud. It had taken me 4 years of pitching a PowerPoint, a year of fundraising, a year of developing, and you launch it, and then no one used it. And then we realized that it doesn't solve the problem. But it did take a long time for the ministry to take us seriously. And then on that note, the microphones come back. So yeah, I think if you're going to get support from the ministry, you have to have evidence. And as a small company, we can't do all the research. So we encourage the healthcare workers using Vula to do research on the data. And if you go to Google Scholar now, and you go Vula Mobile Health, you'll see about 20 publications by Vula users on how they've used Vula. So I think that if you need traction to convince the ministry and you need evidence, and they need patience. And if you've got the right champion in the ministry, things can change.
Oh, yes, it's back. Thank you very much. Well, I don't know if everyone heard that. You may have just caught the beginning and the happy ending, but in the middle, there was a lot of work done by Vula to really ensure that the value add was clear to health workers, and that is what actually basically did the advocacy with the Ministry of Health to get the system to be taken more seriously. Before we come to you, Esther, because I'd love to hear the same thing from your perspective, Will, just one follow-up question. Could you briefly tell us, in very practical terms, what this engagement with the health workers looked like? Because we hear a lot about user-centered design, acceptability, and it's not a single once-off intervention, of course, it's a continuous process. So in those early days especially, when you were starting up, how did that interaction play out with the users?
So, as a small company with a few resources, I think we were 2 or 3 employees at the time. How do you change an entire health system? And so we gave ourselves a challenge is how can we change it with 2 meetings? And so what we worked out is the health ministry is like an hourglass. Lots of politicians at the top who like talking and they rotate and it's very hard to get any traction. At the bottom, there are healthcare workers really working hard who want solutions. And that thinnest part of the hourglass was a head of a clinical department. So the head of obstetrics, the head of dermatology, the head of cardiology, that was the key stakeholder. But then we also realized that person isn't alone. If you're one meeting with that person, you still won't change the system. We realized in terms of behavior change, which was what we learned more about than the technology, that person has to have what we call a team lead, a fellow specialist who believes that this is a good idea and will actually help implement it. So we managed to narrow down the implementation of Vula to 2 meetings with those 2 people. We support them and they tell everyone else to use it. So I guess in terms of getting traction, it's about finding out who those change agents are that can have the maximum impact and working closely with them. But it did take us a long time to figure that out. Yeah.
Thanks. That's really interesting, Will. And change management looks different in every context. Esther, you guys are working with a much more disseminated network of providers, and you started, I think, in late 2021, when we were still at a more heightened kind of COVID responsiveness. How did you get that uptake and that engagement from both the providers and the patients, and then work with a larger ecosystem?
For us, because our product was launched in September 2021, it was around the peak of COVID, so it wasn't very difficult to get the information out that there's a telehealth application, that you don't have to go to the hospital and get exposed to COVID, and people really didn't want to go out at that time, so social media marketing really worked to get the people to adapt the solution. In terms of the professionals, there are literally thousands of doctors waiting for a job opportunity. So it was by word of mouth that. Our founder, like I said, Dr. Betel, works in one of the tertiary hospitals. It's the largest hospital, one of the largest hospitals in Ethiopia. So it's a small ecosystem, the healthcare system. So word gets around that there's an application that primarily caters to health professionals and help them generate income. So mostly it's through word of mouth. In terms of support from the government, so the government has been supporting us by not being in the way. Other than that, so that's really a positive. Sometimes there are a lot of regulations in the way and preventing you from doing what you need to do. At least for now, even the regulatory capacity is not that much. Mostly, I think that's the issue here. So we haven't had many obstacles in terms of the government. Yeah.
Thanks for that, and I'm glad you mentioned regulations and policy frameworks. And again, varies very widely from context to context. Peace, I know with the work that Livestream has been doing in Rwanda, there was a lengthy, and is probably continuing, a lengthy process of engagement with policymakers. Could you tell us a bit about why that was necessary, what it involved, and how it's affected the trajectory of your work?
Okay, so maybe before that, I'll touch on the Kigali Cardiovascular Health Challenge. So it's a challenge by the Novartis, funded by the Novartis Foundation, and the target is to raise awareness on cardiovascular health and early diagnostics in Kigali. And what we're supposed to do is use one of the solutions of Livestream, an AI-based diagnostics to screen for blood pressure in the communities, and also create referral systems with those people who are diagnosed to the nearby health facilities. So here you're dealing with people's data, storage of the data, and what do you use the data for? So that's where all the government institutions come in, because they have to know where the data is going, who has access to the data, and this is understandable. You can just collect someone's medical data and use whatever you want with it. So we had to go through different institutions, and at the start, we had a lot of support from the HealthTech Hub. We tapped into the already existing connections with the Ministry of Health, RBC, the Ministry of ICT. So we literally had everyone on the team. But despite having all these people, we recently got the final approval. So it cost us around 8 months with all that support. So you can imagine what it looks like for everyone else. And so the biggest issue is that we sat down with these people when we were starting so that we know you need A, B, C, D, E, so that we can find whatever they want and the project can move on faster. But then there is no streamline of the requirements, so they figure it out as you apply for those approvals. So let's say if you apply for this approval, they're like, oh, you got this one, let's say 2 months later, but they send it with an application for the next type of approval that you need. And these are things you'd have worked on concurrently, but you couldn't do that because you didn't know. So being a HealthTech AI-based solution in Rwanda, and I would say one of the first ones, it's really hard because you're paving the way. And these people also, they figure out what they need from you when you come to them. So there is no set of requirements that's set way before then. In a way, they're also learning on the job because HealthTech is new, basically. So this has a really great impact, especially to a startup. You're running on limited funds, on limited time. You have to achieve all these milestones, and they're telling you stop with whatever you're running at the moment. You don't have the approval to do so. So you have to pivot, and weren't allowed to use the solution literally for 8 months. And so you're running away from investors, which usually never happens, because they're looking for traction, and you can't show this traction. And you keep explaining, oh, we think we're getting this approval next month. But yes, you get it, but there is a new one that you didn't know about. So it's really a pain, especially because even the people in these positions, they don't have enough knowledge on what health tech is or startups and how they run, and this backfires on these people bringing innovations. I can name multiple health tech-based solutions that just backed out. Like, I'll go sell something else, I'll go in another sector, but I won't go through this process again. Because with all that support, if it took 8 months, for some other people it takes up to 3 years. And you can't run a startup for 3 years and you're not functioning. You're literally zero traction. You can't raise money, you can't make money, so you're literally closed.
Thanks, Peace, for giving us that really, I think, candid picture of what it is to navigate regulatory process, especially when these have not been well defined. I think the point you made about the fact that sometimes policymakers are also learning on the job is a really vital one, and probably one that affects many sectors of innovation, because you're making something completely new and then asking, where do you plug this into the system? The system doesn't yet exist to absorb it. I recall a recent conversation with a director of operational research in a West African country, who's responsible for setting up all the approvals, research, the National Research Ethics Committee and so on. And she said, we're really struggling with AI because we ourselves don't understand AI. The people on the ethics committee have not been trained in AI. This is brand new information. So when we're getting proposals and protocols, it's difficult to even know where to start, breaking this down. And I think this comes to the point of knowledge generation and evidence, which is something that was highlighted earlier as well. There's all this incredible work being done, and I think you've all been very humble about describing your achievements. I would like you to brag a bit more, give us some numbers, tell us a bit more about what your reach is. But with all this incredible work that's taking place, with yourselves and other innovators, let's talk a bit about how that is being documented. There's documentation for the technology itself, but in terms of how that is now influencing the context in which you are, health outcomes. What's your approach to that? How do you fit that into the many other things you have to do, as an innovator? And especially, I think, also on the cost side, are you able to capture all the time that is being saved by health workers because they're now using the Vula app? What is your experience with that been? So since I picked on Vula as an example, William, let's start with you.
Documentation is hard, especially if you've got a small team. So we realized that, during COVID, we didn't do anything with our data until COVID. And my wife actually started our data division during COVID, and it's now it's actually one of the biggest divisions within the company. So every single department that uses Vula gets monthly stats. And at the beginning, we thought, oh, wow, they'll want a cool dashboard. We're going to make this really cool thing online. They're going to look at this thing, and they're going to monitor everything. And we built this whole thing, and again, they said, no, we don't want this. What do you want? And I want a 4-page PDF. And so actually, that's what they wanted. They still have the dashboard if they want it, but that's the documentation on a month-to-month basis. And that documentation enables health administrators to make decisions on a monthly basis. So, for example, one of the departments in KwaZulu-Natal, they've got 4 hospitals, but they've got different resources. And every month the doctors move around, and now they can allocate the referrals on a data-based decision-making tree of where the patients should be going that particular month. And now that's all documented, because every single month when they make a change, you can see the impact. That enables, because you've got this longitudinal data set, that encourages the healthcare workers to do their studies on Vula data, because it's all there. Like, they don't have to go through paper-based records or write things down. If any of your clinicians have tried to do research, you probably remember going through all the folders in the notice room trying to actually collect things. When with Vula, it's all there, which is quite nice. So I think that we can't do all the documentation ourselves. We can provide the kind of the raw material, and then the healthcare workers take over and they start publishing on that data. So I think that's been a key factor for us. And if you want me to brag, it's very difficult, but if you just feel your pulse, or some of you will have watches that do it for you digitally, but basically every time your heart beats, that's how often a patient is helped on Vula. So, I'm sure that answers all your questions.
Beat of healthcare. That's a great one. Esther Ray, I'd like to hear from you as well, because you're also dealing with large volumes of patient-provider interactions. How do you document that, and what do you do with that massive data that you've collected?
The solution has a built-in data collecting mechanism. So we have a dashboard for the in-app consultations for patients that use our mobile application. But the data is sitting there unprocessed. But we do have a collection mechanism. For the call center, after every call, our call center workers, they do the documenting. It's just basically a spreadsheet, and from that a dashboard is generated. Still the data is sitting there. Not much to go in. In terms of bragging, it's hard to follow Will, but yeah. Since our launch, we've had over 35,000 downloads on Play Store. It's not much compared to the market we're shooting for, but it's only been 2 years, and we haven't had a big marketing campaign introducing our product. So we're relying on the post-COVID traction we had, and we've held over 25,000 call center consultations, and on our social media we release learning health education materials that are targeting the public, because the health-seeking behavior in the population is generally low. So there's this trend where patients come to you after they're close to death, because first they go to a traditional healer and then a religious healer, and then they ask their friend for medication, and then after that they come to a doctor. So by the time they reach the doctor, they're usually beyond help. So that's what we're trying to change for now. If there's health-seeking behavior, they'll be able to use our solution. They'll be able to go to the hospital when they really need to. So yeah.
The point you make about the delayed care seeking, I think, also connects well to the sort of work that Livestream is doing. As you mentioned, people don't know that they have an NCD, and it advances to a critical stage, and they might even pass before they realized what had happened. And I'm always very interested in how digital health interventions are able, or not always able, to capture that counterfactual. So the question of what does the world look like in the absence of this? And that's often a problem because you don't have the data for that in the absence of the digital system to capture it. But I'd really love to hear about, Peace, if there's any ongoing, past or planned efforts from Livestream to do more kind of formal documentation, given the ongoing collaboration you have with Kigali City, and perhaps not just to do an evaluation that can assist with understanding not just the benefit of how many people are using this, but also what is the benefit to the health system. Do you have any experience with that you'd like to share?
One thing we decided to do alongside the project is to run a research so that as a way of documenting, because as you said, AI is new, and even the healthcare system needs to see proof before the integration. We saw from yesterday's presentation that when you have proof of concept, usually takes 17 years before that solution is integrated in the health system. So we want to speed up the process as fast as we can. And what we're doing for this research is, first we're looking at the normal screening. So currently we're working with 33 health facilities in Kigali. And so we have nurses in these facilities who run tests using the application, and then they also do it manually, the traditional way. And then we are planning to compare those results in the long term so that we can document how this thing works in this context. And in addition to that, we also want to look at the cost effect. Usually, how much does the government spend to screen one single person, let's say for blood pressure or for blood sugar, and what's the difference when it's done using AI? And we believe by having this information documented, we'll be able to inform and also document the whole process in a better way and make impact in these systems.
Thanks, Peace. So will you be presenting that at the next Investor Summit? Sharon, I hope you've taken notes. Yeah, it's really great to hear that this data is there and that the efforts to analyze it and package it, to show that scientific evidence of the value being added. And it's important, of course, for ministries of health, but also for investors, because that's a key theme of this gathering, is to talk about investments and how this work that's being done in these specific settings can really be taken to scale. We heard earlier that health tech investment is, doing relatively well within the larger tech sector. So there's interest, there's some funding, but of course the reality of accessing that and scaling that as a startup is always challenging. And I would love to hear about what your experiences have been with getting investment to build to scale up your solutions. HealthTech Hub, of course, is one such investor that's really supporting. If you think about the much larger market, as you said, from the 35,000, that's the rate that you're aiming to reach. How has that gone so far in terms of drawing in that interest? And what do you think are some of the key enablers or barriers currently to bringing in the sort of investment to really get to your envisioned target market?
For us, HealthTech Hub is our first outing looking for external investors up to this point. All our solution or all our product has been financed internally. So I don't have much to share on what's it like out there looking for investors. But in the startup community, you do get other startups going through the same issues, experiencing what the investor market is out there, like in our country, because every country's context is different. So you can look at it in two ways. The first one is internal investors, like Ethiopian investors. They're not really looking to invest in this kind of risky investment areas because we are really, so there's like 4 or 5 telemedicine platforms in Ethiopia, and we're kind of the biggest. We take the biggest market share, and it's not much. So we're really introducing this product to the public because it's never been done before there. So no one really wants to take on the risk and invest into this kind of product. And the other one is external investors. So generally, when you look at the investment opportunities in Ethiopia, there are areas you can invest on, but there has been problems with management of the forex that's going in, and when it's time to expatriate this funding, they face some challenges. So there's some reservation in terms of that. So for investors, I think it's time they really risk it out there. They really risk it and put their money into this product because this is what's going to be the future. So, and they need to be patient with their investment because 5 years, 10 years may not cut it. It's a long-term investment when we talk about digital health. So that has been our experience.
Thanks. Risk-averse investors, I think every startup's nightmare. We're going to be taking note also some of these recommendations, to carry forward in this summit. And William, I'd like to see if there's anything you want to add from Vula's experience with looking for investment.
Yes, I mean, the idea for Vula was in 2010, and for 3 years I knocked on doors, and you can only sell a PowerPoint for so long. And I think what we got lucky with was almost 10 years ago to this day, is that there was a foundation that ran a social innovation competition in South Africa, and the prize was $50,000, which is a huge amount in rands. And I really believe that these innovation competitions are really worth applying to for a number of reasons. One is that if you win, you get some cash and you can spend it the way you want to spend it. It's also validation, so the next time you do go to an investor, you can say, look, someone else believes this is a good idea. Often they come with support afterwards, so we are still working with that foundation to this day. They've offered us support all the way through, and that was kind of how we got started initially. The other one which we tried very early on is that who really understands your product? It's not the investors, it's the health workers. They'll know if it's valuable or not. So the first thing we did is we took 10% of the company, put it into a special purposes vehicle, divided it up into 2,000 units, and said to health workers only, if you want to, you can invest in Vula this way. So they don't have direct share, but they have a little stake. And so you had nurses in rural clinics, pharmacists, people who'd never invested anything in their lives, but they understood what this was. And suddenly now we had a whole lot of healthcare workers invested in Vula. It's a great early warning system because if something goes wrong, they'll tell you immediately. If something's going right, they'll tell you as well. And that was a nice sort of thing at the bottom that started us. There was also another $50,000 we raised there. So maybe your investors aren't who you think they are. The investors we did get early on were not nice. We actually said at the time that all investors are sharks. And I was naive. And I didn't have something like the HealthTech Hub Africa. I got burnt by one investor. But that made me very wise. And all those documents that you go through with investors, I know those documents really, really well. I'll tell the lawyer what to do. So I think that maybe the bad experience turned out to be a good one. And then it does take time to find good investors. So we do have a couple that I wouldn't describe as sharks. I would describe them as dolphins. They hold you up when things are bad, and they help you get going. And they are out there. And I think that having things like the HealthTech Hub Africa have really helped me, even at this kind of later stage, providing this network, meeting each other, sharing things. I've already discussed how to get investment with other people yesterday as well. So I think that make the most of this opportunity. Apply for all the funding you can. You can get some nice competition money if you can. And those competitions turn into partnerships. So with the Global Fund, we've got the HealthTech, Data for Health partnership, which I'll talk about maybe this afternoon. And that's now going to hopefully turn into a long-term partnership regarding how to use data to improve health systems. Through the HealthTech Hub, in a way, we also partner with Novartis. Now we've got 2 contracts with Novartis. And it does take work to go through the compliance. And as you said, compliance is hard. And no one funds your compliance work. We spent a year focusing on it about 3 years ago to try and be the leader. But compliance isn't a tick box, it's a way of working. And I think sometimes that's just as expensive as the initial one.
Thanks. Well, really interesting model of getting health workers to directly invest. I think there's a panel tomorrow on innovative financing tomorrow morning, and maybe one of the community pharmacists should have been part of that, because that is a channel that doesn't come up often. A piece you mentioned earlier that during the long process of getting the regulatory approvals for your work, of course, you also had investors wondering what's going on. So I guess you've had a lot of experience with not just managing investors, but also trying to manage the expectations in the context of wider uncertainty because of policies and other challenges that might come up. Could you tell us a bit about that, and also what you think, the question of fast tracking to scale, in addition to investment, what do you think are some of the key requirements that would enable Livestream to really fast track its growth in Rwanda?
So especially in healthcare, I don't think investment is just the money, because as he mentioned, those might be sharks, and there is no way to tell before it's too late. So investment comes in many forms, and one of the biggest investments we have is actually partnerships. And so by just getting the money, and most of the investors, one thing we've learned along the way is to see who wants to invest and why do they want to invest. So the investors who are driven by the impact, they also want to see that same goal, or it's just the money. If it's just the money, it won't work for HealthTech, because you don't know what's coming tomorrow. You have no idea, literally no idea. But then if it's the impact, for example, with the Kigali Cardiovascular Health Challenge, we're able to, since I'm not as humble as my fellow panelists, we've been able to reach, in a duration of 6 months, we've been able to reach 70,000 people in Kigali. So this means, thank you. Thank you. So this means screening, awareness, referrals, and we've been able to reach people who aren't able, or who are not getting reached by the existing solutions. So that's an impact. But if your investor is just looking at how much revenue are you generating by the end of the month, we'll be closed by now. Forgotten, literally forgotten, doors closed. But then, because the investor was looking at the impact, how many people are you reaching, and what type of care are you providing, the quality of the care. So it's looking at the who is that, and what drives what comes with the money besides the money itself. And the other thing I would like to touch on, they mentioned the risk. where investors are like, health in general, it's risky, a lot of regulations. But then it's up to us to change this aspect of the risk by creating the data that's necessary, that they can actually believe that these are viable businesses that can grow and that you can scale. So how do we do that is that you're able to track. You talked about documentation. So whatever we do, if there is no way to track that if I invest this much, this is my return on investment, and it's up to the startups to document this journey so that investors will also be, now they won't see the risk or will be able to reduce the risk because we have the data. Numbers don't lie. So I feel like for every startup, figure out a research aspect to whatever you're doing that adds on, especially in Africa. You mentioned earlier that we're never solving one problem. It's a bunch of problems. So one of them is insufficient data. So instead of complaining every day that we don't have insufficient data, how about you create documentation for the work you're doing? Because you never know if that is combined by this other source of data, that pool will definitely reduce the risk associated to health tech.
Thanks. Really great point on data. And I mean, that's one of the great things about digitization is you have that data. Now what are we doing with it? We could go on, but I think we have about 20 minutes left only. And would really like to open up the conversation. Apologies to people on my right, because I've been sitting with my back to you, so now I'll try to go like this and see if we can start with that side. Any questions from the floor? Fiona's got the mic.
Hello, everyone. Thank you. My name is Olivier. I'm really happy for the discussion panel. It was really interesting. Thank you. I have one question. It's actually a general question. Just looking back, what are the most valuable lessons you learned from your experience, and what advice you will give to our young health tech entrepreneur which have the potential to grow? Thank you.
Thank you. If there are more, we can take another, and then we'll come to the panelists.
Hello, my name is Sarah. I work with Penda Health, primary healthcare provider. I have two questions, one to Dr. Will and one to Peace. Will, you must have, from the screening and the app, Vula mobile app, you fixed one problem, but I'm assuming and asking, did you create another problem in the referral network using the analogy you gave of the hourglass? So now you're getting to hear all these complications coming in from the rural communities, but you have that narrow aspect of the hourglass of specialists and specialist services. What has been your experience there? What has supported that new problem, in quotes, that you have created? To Peace, I understand, and from our discussion yesterday, the innovation you've created is directly to the patient, and it's basically helping them screen NCDs or hypertension from an app, from a selfie. How did you get your patients, and maybe even some healthcare providers, trust the tool? Because I think with AI, many times, even in Kenya, a patient only feels treated when they were touched, when they got an injection, when they felt some pain. So how did you get patients, particularly, to trust that innovation and act on it as an actual screening tool and not a suggestion for it's possible? Yeah.
I know there's another question here, but I think we'll start with these. And perhaps Peace and Will, you can also answer the question from Olivier about your greatest lessons when you answer the specific questions. So let's start here and work our way down.
So I think the answers are kind of similar. So one of I'll say the best lesson learned, it's partnerships. When we started, we were very, very excited to solve all the problems in healthcare. Wanted to have a hospital that has a gym and what else? A swimming pool, mental health side of things. We have nutritionists. we wanted to have everything, the physical space and also the digital solution. But few months in, we realized that first we didn't have the money to do that, and no one wanted to go through all that process. So we realized, because people were mentioning, oh, do you know these people? They do something that's kind of similar to what you do. And being a healthcare provider, we all know we're used to working in silos, so competition, we don't do well with competition. So we wanted to change that. We actually reached out to these people, and one of the first partner we signed, they're called the Health Hub, based here in Kigali. They were our biggest competition at the time. So we reached out, we're actually doing something that's kind of similar. We all want to bring wellness services to the population. Let's work together. They were like, good. But we'll have, to this point, if we kept doing what we're doing at the time, we'd have 0 partnerships and just over there stressed about all this competition in the ecosystem. At the moment, we have more than 15 partners who are health, wellness service providers in Kigali. And these people are still the ones who provide. So on the side, we have incentive-based programs where people are rewarded depending on their achievements or achieving their goals. And these partners are the same people who offer free passes or discounts as rewards to our users. So in a way, we're getting users, but they're also getting clients. So it's a win-win. So the biggest lesson is that you don't have to do everything by yourself. First, it's hard, and you probably won't be able to, but there are a lot of people doing that. So tap into their already existing connections. Their customers can be your customers, and your users can be their customers. And talking about the trust issue, that was our biggest, I'll say our biggest challenge and our biggest worry. But then those partnerships, again, they played a very big role, because it wasn't, especially healthcare information, you want it to come from someone you already trust. When you're talking to these people, they ask, who are you? Are you a doctor? Where do you work? And we have currently a pool of more than 70 agents. We call them Livestream ambassadors. So these are already people in the community. Let's say we have a market here in town. We have people in the market who already sell groceries in this market. And so we train them on how the application works, on NCDs, give them information. And so these are the NCD's contact person in that setting. And if I know you, Sarah, we've worked together for years, I already trust you. I'm likely to trust whatever you tell me than just a random stranger coming to tell me about NCDs. And also partnerships, one of the partners we have is RBC, the Rwanda Biomedical Center. And by just even having the logo on whatever you're doing, they're like, oh, RBC knows what you're doing. And because Livestream is a small startup. So usually you hear people in the community just saying, oh, RBC people are back. And we're not RBC, but we're working with RBC. But that creates the trust. They can trust whatever information you're bringing to them. But also tapping into the already existing health facilities. I mentioned that we currently work with 33. So it doesn't necessarily have to come from the Livestream end. It also comes from the healthcare providers themselves. If they trust it, then the community is going to trust the solution. Thank you.
Thank you, Peace. Really great answer.
Yeah, you've taken a lot of, I also want to talk about partnerships, but I'll have to think of something else now. I think the one thing I learned early on is that just because it's a good idea doesn't mean it's a good business. And it took me a long time. So it was after that foundation that funded us 10 years ago. In 2018, I asked for help because we hadn't made a cent. And they gave us a consultant who helped me kind of work out a commercial model. So I think that was one thing. And then coming from being a physician, you want to be friends with all your patients. But business isn't always like that. And we have a Dutch investor who said that a soft doctor makes for smelly wounds. And so I was being way too soft. And sometimes you make a bad hire, and you have to do hard things. And so the opposite of that is what my counselor said, that the softest part of you must be your teeth. So sometimes you have to make really hard decisions and make them quickly. You can't afford to wait for a wound to get smelly. So hopefully that gives you some. I'm happy to talk later about what that really means behind the scenes, but yeah, maybe that helps you. And then in terms of creating your own problems, we built it to solve one problem, and then what? And so we tracked it over time, and I can give you 3 examples. One is there's a nurse who worked 3 hours north of where I was as a specialist, so further than I was as a rural doctor. And she would refer cases to us, and so you sort of get to know someone over time. And then suddenly she stopped. And we thought, oh no, something's happened to her. She's been on a road, there's been an accident or something. And when we called her, she said, no, she's fine, but she knows what to do now. So yes, initially you are doing work, but actually every time you are using Vula, it's upskilling someone in the periphery. And then beyond that, she used the data that had been collected over that time to demonstrate to the Department of Health why there should be a specialist clinic out in the middle of nowhere. And today that's one of the best clinics in the country. And once a month, a surgeon goes to help her with the difficult cases and operations. So you've reversed what I experienced with data and with sort of one-on-one training. Another example is with the University of Pretoria that used it for teaching students. So the students would go to the clinics, they would refer patients to the prof, and the prof would then teach them. And then they would take the questions asked per age group and adjust the syllabus according to what the students were seeing rather than what the textbook had been saying for 20 years. And then there was one case where all the students were giving exactly the wrong answer and all giving it in the same way. And they couldn't work out what the problem was until they found out there was a mistake in the textbook, which had been there for 20 years. So I think people start using the data in innovative ways. And then there's another hospital called Tlua, which is near Butterworth. And they referred to another hospital called Freya. It's about an hour-and-a-half drive, and there were 60 ambulance trips going every month. Then they used the Vula data to say why. And it was hand and foot injuries from farming. So now they send one surgeon with the right equipment once a month. Everyone gets operations. You don't have to all those ambulance coming through. So again, when I first built Vula, I didn't think, oh yeah, that's what's going to happen. But people use the data in very innovative ways. And then you create new problems. And then they said, okay, well, you must also have it to add new specialties to Vula. So now I want to add the physio to my chat. I want to add the occupational therapist. I want to add someone from another hospital. So now we keep having to iterate. So I think it kind of comes back to you, just keep iterating. Like, you're never finished. So, yeah.
Thanks. Well, and Esther, when you're responding to the lesson, I think it'll also be interesting to hear your thoughts on building trust. Telemedicine isn't exactly AI, but there's still that conventional expectation that I see a clinician in person, and who knows who's on the other end of the line. It could be your teenage brother putting on, Grey's Anatomy persona and pretending to be a doctor. So how do you also manage that and build trust on both sides as you also speak to your greatest lesson?
I'll start from the lessons. So the lessons is one of the lessons we learned is the pitfalls to avoid when you're a startup company. So that is in fear of the sharks Will mentioned. Like, you're so in love with your product that you don't want to lose even a little bit of equity, and you don't want to lose control, that you try to do it on your own. But when it's a startup company and it's usually a new idea, it takes time to build traction and to really get some financial investors, get people's feedback on your product. So that's really one of the lessons we've learned in our company's journey. The other one is, so going back to the building trust, and so we have a rigorous vetting process when enrolling health professionals. So if we didn't have, right now we have a network of around 2,500 health professionals, ranging from general practitioners, subspecialists, psychologists, and other, we also have home care nursing, I forgot to mention previously. So we provide home care nurse service. So there's a process, there's a vetting process that they have to go through. They have to provide their license. They have to, and has to be checked manually. So we send a form for them to be fill manually, and then we collect that and we vet the professionals. So there's that, and then getting the people to trust your solution. So you have to. It's really, medicine works by really word of mouth. So and so, I called so and so, and they provided me with the solution. So you have to really make sure the doctors, the professionals you're putting on your platform are well equipped, and they're professionals that can handle whatever comes their way. So it really has. It's really your homework to make sure that you're providing a quality service, and so you in the end you rely on word of mouth.
Right. I think you've all really emphasized the value of change agents, whether it's the officer in the clinic, word of mouth, your ambassadors in the market, and something that we'll take away. I know there was another question in front here and on that side. Okay, we'll start on that side.
Hello, good morning and good afternoon. I am José Mtabazi, and I have two quick questions. Well, I am a digital health advisor at Japaigo. And the very first question is kind of general to the panelists. Regarding to the user data and user privacy actually and data protection, how is your experience aligning with the evolving data protection regularly across different agencies, the government and the rest of the institutions? So that's one. The other question is, what's your experience in deployment and implementing these AI-based digital solutions to the end user side, like getting these tools used across? And I'm asking this because I'm currently a part of the AI and Data Exchange Task Force for the Ministry of Health in the RBC, Rwanda Biomedical Center, and a part of a lot of things being done currently is aligning and making sure that all these digital solutions really get the benefits that they deserve in order to really make impact in healthcare. So I'm just trying to understand what was the journey deploying and implementing these digital solutions, mostly AI-based, across the end user, to the end user perspective. Over.
Yeah. I'm Geza Ferrier from Novartis. Thank you so much for your inspiring stories. There was one thing that piece you said, which almost broke my heart when you said that you had to wait 8 months and you could do nothing with your idea until it was kind of going through rounds of approval. And similar to the comment that you just made, actually, I'm thinking how important it is to take those along with you who are going to have the decision in their hand. And for everyone, it's a learning journey. And for us as a pharmaceutical company, it's basically the same. When we come up with an innovation which is really groundbreaking, no one will have the experience to even, judge upon it. So it's so important to take stakeholders along. So I would be interested in your, learnings that you've had and how you would implement it differently to give us hope. Thank you.
Right, we'll take the last question in front here.
Okay, thank you. Good afternoon, everyone. My name is John Eremosele from Lecturio. I have a question and I also have a comment. So my question for you, Peace, is, yes, you talked a little bit of the failures or the challenges. So we want to know if these approvals we are waiting for included those from government and regulatory agencies like regulators within the medical space. Then, because we want to see what are the roadblocks in concrete terms, like you had to experience. Because many startups, I think most times when they just face the roadblocks, what they do is they stop there or they go back. So we want to know how to work around those. Then for you, Lema, you have lots of data. Data is very powerful. And to me, I think I see it as it's sitting in a silo. So my comment or suggestion would be you could aggregate this data. I know these are health records or data that you might be also thinking about privacy issue, but when they are aggregated, you can make them open, and you don't need to develop your own open data solution. I think there is an open data hub like African Data Hub. You can create an organization in your name in the hub and upload all your data sets there and make it open. Then you can organize hackathons and you'll be amazed of what innovative solutions could come out from these data sets. Thank you.
Thank you. We said that was the last question, but there was someone here who had a burning question, and I'm afraid she beat you to it. So we're going to have to give her the mic, and then we'll turn back to the panelists because we're almost out of time. Sorry.
Thank you so much. My name is Jael Walukwe, co-founder Higher Africa, focusing on maternal and infant health. So my question is, based on what you've mentioned and the experience and where you are now, which factors do you believe would have accelerated your time to market and solution launch?
Thank you for that concise but profound question. So I'm going to just make an executive decision to divide up the questions in the interest of time. Esther, I think you've had a comment about data integration and how data could be utilized in more interesting ways, which connects well to Jose's question about data protection, because you have to balance the two. So if you could perhaps speak to that, what the context is in Ethiopia with regards to data regulation, how you're engaging with that. And William, will come to you to answer the same question. Then I think, Peace, you'll take the ones on AI.
So in terms of the data regulation by the government, it's still in development stage. That there are compliance. The application has to be compliant to there's a security agency that regulates how data is supposed to be protected and how it's kept, how your solution is protecting the data you're collecting. So we had to go through that compliance stage, and we had to redevelop our application after it was already made, because the policy is being written as we're developing our solution. So we have to go back again, and we had to redevelop our program. So when using, that's part of why we're still sitting on this data, particularly the patient data, but in terms with the health professionals, we have an agreement that we are able to use this data in certain contexts. So it's one of our revenue stream is that we are able to generate partnership with local health institutions such as medical travel agencies, pharmaceuticals, and other health institutions. So we're able to use this data. So we are able to use it as a source of revenue. But in terms of the patient data, we still are unsure how to use it. That's why it's just sitting there, not being used. So thank you for the great inputs, the gentleman.
Okay. And perhaps before we come down the line, the really important question as well of what would have shortened the time taken to get to market. I think this will be our last round, so you can address that and any final comments too. Yeah.
To hear this from Will, really.
I'm going to answer your question and yours at the same time, because how do you go to market faster? We did it with Jipaigo in Ethiopia. So with Namibia and Botswana, with our partnership with Novartis, we learned that if I go alone and I knock on the Ministry of Health's door, it's like, hi, I'm Will. And it's like, oh. But if Jipaigo go to the Ministry of Health in Ethiopia and say, hey, we've got the solution, we want to roll it out, it's like, okay. And so having learnt in the other countries, in Ghana with Novartis sickle cell and with obstetrics in Ethiopia, from signing the contract, we were operational within 3 months, which was Now we know how to do it. Thank you. That was a key factor in making sure it was done. So we had all the compliance documents in place. But again, if I'd gone to the ministry with those, I would still have a long process like you decided. But by having a well-established partner in the country, it just sped up that process dramatically. So it's one thing to have the information, it's another thing to convince someone that it's actually correct. And if you don't mind, I wouldn't mind touching on the AI question, because we've done some experiments. So I think in 2019, we thought it'd be so cool. We've got so much TB data, tuberculosis data. Wouldn't it be amazing if you could take a photograph of the X-ray and the ruler says you got TB or not? And so we trained this algorithm, and it was amazing. And then we told the health workers to use it, and they said, no, it's not useful, because providing a percentage chance of the X-ray having TB isn't actually useful. Treatment is binary. You treat or you don't treat. You don't get like 30% of a tablet because there's a 30% chance of TB. So we realized then that failed. We didn't make a useful AI. And then to make AI work, you have to have data. And then using that data for AI, it took us 18 months of compliance work to work with Google and with 2 universities at the same time to get them to have a contract around dermatology. So read papers. The Google Dermatology DermAssist at the time was only trained on 3% dark skin. So basically useless for us. And so I read the paper, and I wrote some letters to them or emails, and I said, you better talk to us. And then they said, well, we pay $7 a case. And I said, well, we're more valuable. And so we got $14 a case, half of which goes to the dermatology departments who are doing all the work. And so now you're resourcing the specialist departments. So you created a problem, but you're not finding a solution. So now they're getting more funding into the departments, and hopefully the public available AI will be useful to us in the future. I can't guarantee that given our previous experience, but hopefully making some headway.
So one thing I'll mention about the compliance, actually I didn't want to point fingers, but one of the people we had to comply with was the Data Protection Office. So there is the data controller, data storage, and data processor approval that we needed to secure within that office. And we have those now, thankfully. And you mentioned like government institutions. The thing is, you don't know, especially in health tech. So first we reached out to the Ministry of Health, and they were like, oh, we think you should go to the Ministry of ICT because it's tech-based. But then the Ministry of ICT is like, you're in healthcare, go back to the Ministry of Health. So you don't have where to go. So you're stretched in between, and you have to figure out, sorry, I'll touch on the speeding up the process. As a startup, you're literally a baby, and a baby needs its mother for several years. So you need to find your mother in the ecosystem for you to survive the first few years. Because if you're attached to that bigger thing, then that will push you to the point where you're able to stand by yourself. And for us, that has been the HealthTech Hub. And so it's been pushing in terms of support, connections, whatever we needed at the moment. And talking about what we can do at the moment, we're part of the first cohort of the HealthTech Hub, and we had a lot of mentorship, a lot of amazing facilitators. And one thing we have, the same way we have, let's say, investor readiness, I feel like we should have something on the compliance readiness, so that startups know beforehand that this is what the scenario looks like, this is what you will need moving forward, because there is nothing like that. So you have no idea what you're getting into, and it's costing you time that you don't have as a startup and resources that you do not have. So having that type of mentorship beforehand that comes with all the other available support, I think will be really helpful to startups.
Thanks, Peace. And I think we've had some really clear recommendations coming out of this. We're out of time, unfortunately. There's clearly a lot more to discuss. I'll try to do a quick recap of some of the takeaways that I've been noting as we proceeded through this discussion. First of all, we started with the problem. Understand the problem, lean into it, ensure that your solution isn't creating more problems, and you do that through the constant interaction and iteration of solutions. Something that has come up repeatedly, number 2, regulations, compliance. It seems that startups are spending a lot of time not just trying to comply with regulations, but trying to understand exactly what these regulations are. And that's often a shared thought process with ministries of health who are also figuring this out as they move along. So I think Peace has given a very clear suggestion around mentorship for compliance, but also clearly there's a need to think more broadly about what sort of capacity building is needed to enable partners in government and in other sectors to really develop robust regulations. You know, for health, this has been done for many other areas, you know, medical products. What sort of approaches could work for digital technologies? And I think that's a challenge for all of us, and especially for HealthTech Hub, that is really fostering a lot of this innovation. Thirdly, data. So much data is available. How are you using it? Not just to tell the story, to report on what you're doing, to publish evidence that can inform some of this capacity building and that can also make investors interested in the work, but also how can you use it to constantly improve quality, to ensure that your value add keeps getting better and better. I really like the point you made, Will, about the nurse who stopped sending requests because she now knew what to do. And the process of getting your turnaround down to 30 minutes in order to ensure all digital solutions have the potential to constantly be self-improving if they interact with the data. I always have to quote something that Rob once said in a call, that data is the only thing that defies gravity. It goes up, but it doesn't come down. And I think it's a challenge to innovators. If you have this huge body of data, how are you reflecting on your own work to make sure that it's improving yourself while complying with data protection laws? To investors, we heard a bit about the nervousness to invest in things whose return may not be immediately apparent. This is a long-term journey, and there are many hurdles that come up along the way around compliance and such. And I think it's really clear from what has been presented here that startups are thinking about this in very, very thorough ways and engaging with folks. And I think a lot of credit is really due to HealthTech Hub for everything that's been done to bring investors and startups together. And finally, on that same note, partnerships. And that speaks to everyone in this room, whether you're an investor, a policymaker, a clinician, an innovator. The point about change agents, I think, is something that each of us can take on individually. So I'd really like to encourage you to do that. Figure out from what we've heard here today, what are the ways that in the work you do, you can help to address some of these challenges. Please engage with the startups. I know there were some questions that we couldn't get to. Feel free to approach them. I hope they don't mind. Anytime, I think you have some exhibitions as well around the grounds. Thank you very much to the panelists. Let's give them a big round of applause. And a big thank you to HealthTech Hub for bringing us together again. Have a good afternoon.
As they exit the stage, another round of applause for our amazing moderator and our panelists. Indeed, this was an amazing conversation, very in-depth, very detailed, and it draws a picture of what startups are really dealing with when you're looking at the health tech sector, challenges, opportunities, and really encourages us more that there is still more opportunities for all of us to get on board and all of us to continue creating solutions for the challenges that we have here within the continent. And now we're going to go for lunch. I know we've had a very long morning, but with very crucial and very important conversations. We still have Wilfred with us, who did a presentation earlier on, as well as Dr. John. In case you have questions, as Paula said, please feel free. Get close to one of these people during lunch and do share and as well as network. When we come back, we'll get pitches from 6 startups. That is something that I'm really looking forward to, getting to hear some of the different solutions that we also have within the sector. And then we'll get remarks from the President of Global Health and Sustainability at Novartis International, something I'm also looking forward to. And later on, we'll have the HealthTech Hub Africa Startup Exhibition and reception. All of you, bon appetit. See you all back here by 2:30 p.m. for an exciting afternoon. Thank you all. seated on the left side of the pergola. So lunch is on the right side, on your right side. Just, everything will be set out there. Thank you.
Ladies and gentlemen, welcome to day 2 of the Investor Summit by the HealthTech Hub Africa. We really have a lot packed up and we're really looking forward to having you here at the HealthTech Hub. Ladies and gentlemen, welcome to day 2 of the Investor Summit by the HealthTech Hub Africa. We really have a lot packed up and we're really looking forward to having you here at the HealthTech Hub, hosted at Noscan House, Kigali. Ladies and gentlemen, welcome to day 2 of the Investor Summit by the HealthTech Hub Africa. We really have a lot packed up and we're really looking forward to having you here at the HealthTech Hub, hosted at Noscan House, Kigali.
More coordinated investment in the rollout of digital tools and where investment should be concentrated. So very much looking forward to the upcoming sessions where we'll hear more concrete examples from people who are actually implementing these solutions on the ground. So I've also really enjoyed the sessions this morning from both the clinician as well as the investor perspective, particularly around the challenges in the region for operationalizing and implementing digital solutions, but also on the contrary, what the opportunities are when they are.
African continent. Ben has worked with entrepreneurs in the network to raise in excess of $800 million in VC funding. Ben is also the co-founder and first general manager of AfriLabs and is the co-founder and vice president of the African Business Angels Network, ABAN. A round of applause as Ben comes to the podium.
Wonderful. So very happy to be here. Our friends at Bridge for Billions asked if we could work with some of these entrepreneurs to help prepare them for their engagement with investors and to help increase some of their visibility with the investment community. And so we're super excited to have these entrepreneurs here with us today because we're waving a flag, right? Saying the healthcare industry, all of these terribly complex challenges, how can we turn them into opportunities? And so we have to be super excited that we have bright talent from across the continent that has responded to this question. And they're here today to tell us more about their businesses and to share their progress. So as was just mentioned, let's give these entrepreneurs a huge amount of support. Let's clap our hands, let's yell, let's hoot, let's holler, let's celebrate their efforts. The second thing that I would ask of you today is from this audience that we have today, there is an incredible network, a shared network of contacts that we have. So even if you're not going to be investing in one of these companies, you know somebody. You have a connection to a possible partner. So when you're listening to this entrepreneur, think about different ways that you can help. Please step forward and share those resources with these founders so that they can continue growing and building these businesses. The third thing is that in November 18th to 20th, we will be organizing deal rooms and deep dives with each of the founders. So if you would like to get more information about the company or you have investors in your network who would be interested to meet these companies, please share your contact details with either myself, Ben at vc4a.com, or one of the entrepreneurs so we can make sure you get the information. But so without further ado, entrepreneurs, this is your stage. Let's go.
Thank you so much, Ben. And the first pitch, we're going to hear from Babajide Oke, founder and CEO, Render Health Technology. Okay, I'm going to just give maybe a bit of your background as the technical team also helps you to get set up. He has several years of extensive experience working in the biotech and healthcare sectors across numerous hospitals in the United States. He specializes in analyzing patient clinical data in relation to investigational products and has been involved in several oncology and infectious diseases trials. He then returned to Nigeria where he founded Render Health with the goal of making a positive impact of healthcare. He's going to have about 10 minutes, and then after his presentation, we'll have about 3 minutes of Q&A.
Hello, everyone. Good afternoon. I hope everyone having a good lunch. While I'm waiting for my pitch to come on, just going to chat with you guys a bit here. Okay. Hello, everyone. My name is Jide, and thanks for the intro, making me feel much bigger than I am. But yeah, so my name is Jide. I run a company called Render Health Technology, and what we do is Render Health Technology is a payment and data analytics company, and what we are doing is basically bridging the gap using payment and collecting data behind healthcare payment. A lot of people have said a lot of things today, and I think one thing I want everyone to know today, within the African ecosystem, most of the payment for healthcare is done out of pocket and with cash. And what we do is collect all the data analytics behind payment data. So I think one of the first things I want to look at is let's look at some of the problems within this market. So a lot of payment is done out of pocket. And because it's done out of pocket, there's limited financing because of different socioeconomic status of patients. There's also low patient health insurance because of income level spaces and huge gap and lack of accurate data. So because a lot of payment is done via cash, there's no transaction history. So I just give you the money and you give me the medication, or I give you the money and then you just tell me the service. But the data behind all that is never captured, and most of the time it's lost. So how are we solving that? We're solving that with our solution, which is a physical card. It is called the Render Health Savings Card. This card is in the middle of three important things in the healthcare system. It's basically optimizing healthcare billing and payments. And with that, we're able to collect precision data in healthcare and work on providing accessible healthcare financing option for patients who are paying out of pocket at point of care. So I think one of the things we need to look at is you need to understand the patient journey for you to understand how exactly is this card solving the problem. This is current patient journey. Patient goes to a healthcare facility and they seek treatment. And the patient has to pay. Because in Nigeria, I'm not going to speak for Rwanda, but in Nigeria, if you don't pay for healthcare, you don't get it. They'll tell you to go find the money, and then when you have the money, you could come back. And then now when you pay for healthcare, you receive treatment. That is how it works typically. But now, with our solution, we are trying to change the patient journey with the Render Health Savings Card. This is how it works. The patient seeks treatment, and then they get a card. So when they get a card, a few things we collect from them is we want to understand each payer. We don't want to call them a patient. How much does this person make? What is the socioeconomic status? Are they employed? Are they unemployed? Are they the head of the household? Are they the one paying the major bills in the house? Because so with that, we're able to kind of understand, okay, this patient can afford this kind of medication, this patient can afford this data, this patient can or cannot afford something. But with that, we're able to kind of access, this is what this patient can get. And then they use that card to make payment. When they do that, they receive payment, and what we do is collect the data at the point of care, at the point of payment. So for example, a patient goes to a hospital and the doctor tells them, oh, do a CBC test, urinalysis, an x-ray. Usually at that point, you take that file and then you take it to the cash point. And they just ring you up, they just tell you manually, go pay 10,000 francs, for example. And then you pay for it. But the data behind that is lost. So with the Render Health Savings Card, we're able to actually capture that on your Render Health Savings Card number, that this patient went into this hospital and they did a CBC test, a urinalysis, an x-ray. And then right after, when the doctor gets the result and the doctor prescribes the medication, the same process happens. So then whatever medication they're prescribed, then they're able to document that, and that is stored within the patient's Render Health Savings Card. And that Render Health Savings Card basically holds the patient data wherever whatever healthcare facility they visit, be it a pharmacy, a hospital, a diagnostic center. And that is how we're able to collect the data behind healthcare payments. So I just want to, why should you use a Render Health Savings Card to make a payment? Well, you're able to use this card at all access points for healthcare services. So this is going beyond just hospitals. This goes to pharmacies, diagnostic centers, primary, secondary, tertiary healthcare centers, including public and private institutions. So we're able to also reward patients every time they spend by working with different partners, and also provide flexible payment option, cost saving, and we also are making sure that depending on your socioeconomic status, you're able to get care wherever. So here's some business use cases with pharmaceutical companies. I think a lot of people here are from Novartis. We're able to kind of work with you to be able to provide patient reimbursements, use it as a source for data and analytics in the African market. For NGOs, you're able to kind of get more tracking of your expense to whatever cause you want to support. Government could use this to be able to get data analytics of the environment for insurers and also for pharmacy chains. So what are our attractions? We currently have 21 healthcare facilities currently using this with different notable pharmacy chains in Nigeria. We have issued over 5,000 cards. Virtual, we just actually switched to a physical card because as a virtual payments, we had some issues. In Africa, we like to touch things. Virtual payments is very tough. And we expanded our user base. And because of this limited traction, one of our major attraction is that we're actually working with a state in Nigeria that sees an average of about 5,000 patients a day to digitize the whole payments structure, whereby we'll be issuing Render Health Savings Card to patients, and that will be the form of patient within the healthcare system. So this is our future roadmap. We begin our launch our pilots in Q4, and we're looking to expand to other countries in Q2 of 2024. And one of the things we're looking for is diaspora market. So we want to reach out to people. They could send funds to their family and friends to this card, and they know that you can only use this to pay for healthcare-related expenses only. And also, we're looking for an international partnership in 2025. And I actually met somebody here in Ghana who wants to work with us. So yeah, might be faster than 2025. Thank you. So what are our market opportunities? I think Vilgro said this. In Africa, payment systems are going to $258 billion by 2030. This is something that was actually, I'm just kind of reiterating what somebody else, one of the investors said here. And there's 1.3 billion payers in this market, 600 million uninsured who pay out of pocket. And in Nigeria, for example, 8 out of 10 pay out of pocket. So this is our revenue model. Just transaction fees, data licensing, overtime, one-time overdraft fee, and also strategic partnership with pharma companies. These are some of our partners that we're currently working with in this program. This card is actually built in partnership with InterSwitch and Providus Bank. And this is our chart. This is what we see as the future of healthcare spending in Africa, a combination of a Render Health Savings Card with insurance and also working with also different donors to be able to make sure patients are able to get healthcare when they need it at point of payment. Thank you very much. And we're actually fundraising next year. Any interested investors, we'd love to chat you up. And this is our team. I'm Jide, and I have some of my team here with me. And I think she said a lot of my bio, so I don't want to reiterate that. And John is our CMO, and Tita is our CTO. Thank you very much. I'm happy to take some questions.
Thank you so much for the presentation. I'm curious with the zero interest credit, how much are you able to make per patient, lifetime value per patient and versus customer acquisition cost? And what's your traction to date in terms of revenue?
So right now, the financing is not a model we've started, but it's a model we've had conversation with healthcare facilities on how it will work, and they love the idea. Because you have to understand that healthcare facilities want to get their payments right immediately. So what the model the conversation we had with public healthcare facilities is, if you give a bill to a patient and we do agree to work with our partners to finance it, then there is going to be a reduction in service. So that is why they could do zero interest, because the hospital is able to get the payments disbursed out immediately at a discounted price, while the banking partner is able to recuperate from the discounted price when the patient pays in full. So revenue stream right now, we are kind of focusing on just getting our transaction fees are mostly our revenue stream right now. And also we are working with data partners such as IQVIA to monetize the data. So right now, Dave, we've generated 10,000. This is a Render Health Savings Card product. Is a product we just launched this year. We shifted from EMR to this service due to the need that we saw from our customers.
Thanks for the presentation. Quick question: what does the process look like? What does the process look like to integrate the Render Health payment system into a healthcare facility?
Yeah, so I think it's quite, that has actually been a challenge, and I'll tell you why. So you have to understand that in the African market, a lot of things are still on paper. Even when you want to pay for something, they have to take a book and flip through it and tell you what it costs. So the first step we do is we collect your tariff. So what do you sell? And then we categorize all what you sell into different categories. Is it X-ray? Is it imaging? Is it consultation? Is it diagnostics? Is it medication? We break those down and then we upload it to the back end. So what is the challenge is that you'd be surprised that a lot of healthcare facilities, well, in Nigeria, they don't actually know what they sell. So we have to kind of sit down with them, trying to get it, and then once we get it, you have to digitize it. So that process is actually very, very, that's one of the most painstaking processes we have to do. So we get that, we upload that into the back end, and then now when a patient comes to receive a service, they just get the patient's Render Health Savings Card number, which is at the back of the card, and then impute that, and they charge them off the tariff. So that is how we're able to accurately collect the data, basically using payment.
Thanks.
Any other question?
Thank you for the presentation, Jide. Maybe you can talk a bit about the Oyo State pilot. Like, how many patients are you targeting there? Are the patients required to actually take the card, or can they opt in, and how would they be convinced to opt in?
Yeah, so in regards to the pilot is going to involve 2 cities within Oyo State. So it's going to be a city called Ibadan, which is about an hour and a half out of Lagos. Lucy's been there. We drove there together. So it's about an hour and a half out of Lagos, and then another one called Ogbomosho, which is another 2 hours from Ibadan. So it's going to be comprised of both tertiary, secondary, and primary healthcare centers within the hospital. So physical cards are actually going to be issued at the tertiary and secondary healthcare centers. When you request a card, in the primary healthcare center, an account is opened for you, and then it's shipped from the secondary or tertiary to the PHCs for pickup, or you could just go to the PHC depending on the distance. So now the way it's going to be mandatory for each payer, because that is how we actually able to work with the Ministry of Health to be able to show them the data of what is going on within different regions. So within a specific region, we can see that a lot of people in this town are buying a lot of malaria medication. So that means something is going on there. Or a lot of people in this area are getting typhoid medication. So something is going on there. So it's going to be mandatory, and then we're going to try to expand the pilots as it goes to different healthcare facilities. And averagely, we're currently targeting about maybe between 700 to 1,000 patients per day for our initial pilot.
Jide, can you share with us for this first project, with this first state in Nigeria, except for the government, who else would be your ideal partner if you have to pick one type of an organization, and why would that be the ideal partner?
Oh, Lucy's always going to put me on the spot. Our ideal partner will be pharma. I think they'll be an ideal partner for us. Well, pharma is NGO. It's kind of tied because we're looking at, if it's one, we have to pick pharma. The reason we were looking at is that there's a lot of opportunities that we see. We're able to provide market insight. We're able to basically provide, it could be a source of reimbursement for pharmaceutical companies, whereby, if you buy this medication, you're able to get some percentage back for customer retention purposes. So yeah, I think that would be one of our ideal partners that we'd love to work with.
Thank you so much for that pitch, as well as also the questions that we got. Your time is up. Really appreciate a round of applause for Baba Jide. We're now going to hear from Jerome Shimimana, founder and CEO, Joe Group Limited, /JoeCare. Dr. Jerome Shimimana is a visionary healthcare leader with a profound commitment to addressing pressing healthcare challenges in Africa. With a background in medical sciences and a fervent passion for innovation, he is at the forefront of revolutionizing healthcare industry in low-resource settings. A round of applause as he gets to start his presentation.
Thank you. Okay, thank you very much. Ladies and gentlemen, it's an honor to be here in this afternoon. I'm Dr. Jerome Shimimana, and I am the medical doctor by profession, and I'm the CEO and founder of Joe Group Limited, where in Joe Group Limited we are implementing a project called JoeCare. So in JoeCare, what we are doing is just educative platform about health. We are educating, mainly focusing on sexual and reproductive health, non-communicable disease, and also mental health. Our journey started by the story where we've met a young lady during my clinical rotations who got pregnant unintentionally. And by that time, as a young medical professional on training, I said that I have to do something for my community because I have seen that there is a gap or lack of information about sexual reproductive health. And later on, we have seen that also in non-communicable disease and also in mental health. That's where it started. And also by that, the problem was increase of teenage pregnancy because I have seen that there's increase in teenage pregnancies. And also other thing which was there was increase of non-communicable disease. And as you can see here, you can see that NCD accounts 44% of all deaths here in Rwanda. And during my final year medical school, I conducted a study. My thesis was focusing also on NCDs because it's what we're focusing on JoeCare. And also we have seen that there is a prevalence of diabetic ketoacidosis here in Rwanda about 36.4%, and also HHS about 8.3%. So I have seen that if nothing is done here, we are in trouble. That is the reason why JoeCare came in. JoeCare, we came as a solution. We came as a solution because what we are doing, we're dealing with online platform, which is educative platform. And as also we are serving the community, which is also non-developed, also we have also to account that we have to put into consideration those people who are in rural areas. That is the reason why also we are having some hard copy materials that we are using, even if we are a health tech company. And also we are tackling on SDGs for the education and also about well-being of everybody. So for us, this is how Jokea look like. And the other thing I have to mention is that in Jokea, we are including those people with disability. Because as that young lady I told you from the story was disabled, he was blind and also deaf. So by that time, we hear that whatever we are going to do, we have to put into consideration those people who are disabled. That is the reason why on platform, you see that whatever we do, we are also including those people with disability. Whatever we do in our educative way of what we are doing, we also include those people who were left behind. So for us, in education service, as I mentioned, we have a huge market opportunity here in Rwanda, because also, not only in Rwanda, even in the region, because many people don't know about health. And the reason why we are focusing on education is that for us, we believe that informed community is healthier community. I hope that everybody understands about that. That's the reason why, and also whatever we are doing is just prevention rather than curing. As a medical doctor is our main role. That's the reason why whatever we are doing is just educating before people get sick. That's what we are doing at Jokea. We have a huge marketing, and also our business model is mainly focusing on 4 pillars, if I can say so. The first one is health education services. For us, we are educating individuals, people themselves. We are also educating companies and also institutions, governmental institutions, and also schools, and also other people who want that we may go there to train for them. We do that service. And also the next one we do is on the digital health. What we are doing at Jokea, also people can enroll to our platform, and also they can run those lessons from what we are doing. And also other thing we do is collaborative partnerships from also government organization and also non-governmental organization. And the last one also we do research and grants. So from that research and grants also we are conducting studies. It helps us to sustain and also to keep expanding. And we have like some, if I can say, like competitive advantages. Whatever we are doing is that we are all in one. As you can see, we train all people and with inclusion of people with disability, and also with our strong partners, mainly having this HealthTech Hub Africa, also in the University of Rwanda, supported us to reach to our goals, just either in training and also to reach to the community outside there, and also integration of those HealthTech, the technology into what we are doing, and also inclusion of those people with disability. And by that also we have some tractions. We have been able also, we are in top 10 scale-up project here in HealthTech Hub, and also by not only by the sales or also by the contract we are signing with those institutions I mentioned above, and also we received some grants also to help also to scale up and to sustain our project. And also I can say that for investors who are in the room, so working with us is not just only like a business opportunity, but also it's like, I can say that it's also supporting the community to be aware of what is going on, health information, just delivering information to them, which help them to prevent the diseases. I can say that also Jokea needs. Currently, we are raising $250K US, which can help us to strengthen our tech, and also to help us in the marketing and also to our operations. And we have reason to believe in us, because we have done this from 2020 after pandemic. So this is like over 2 years past. So, and we sustained, and also we are still working. And also for us in the future, like 5 years, we can see us like global expansion, just not only working here in Rwanda, but regional and even beyond Africa. And also for the cutting edge about researches, as I mentioned about it, also just conducting researches, because in medicine what we do is just evidence-based. That is the reason why also for us we're also focusing on conducting researches. And also profitable growth, because we want to increase the sales and also want to increase those partnerships, and strong partnership, and also those people who can work with us. So I call you to act and also to join us, join our movement, and also to work together so that we can have an informed community. And also we believe that informed community is a healthier community. By that, we hope that everyone will be happy. So by closing, I may say that for us, we have a strong team. You can see Dr. Jerome, and also the doctors, and also other people who are in HealthTech, and also people who are in other services who are also experienced. We have a strong team and strong partnership, as I mentioned. So you have to believe in us and also work with us. And we hope that with this, we will be having an informed community, which will be better for our community. Thank you very much.
Thank you. Any questions for Dr. Jerome?
Thank you. So my name is Adrian from HealthTech. Maybe not a question, more a comment, and it might be applicable to some of the other startups here.
Yes.
I know you are delivering training content to the patient community, and we also dabble around in e-learning in the South African space, specifically in the HIV space. And something that we discovered is something called zero rating or reverse data billing. So you can work with the telco providers, and then that training content that you deliver to patients, you can actually zero rate it so that the patients don't pay for the data charges when they actually use your platform. So it's working really well in South Africa. I know in Kenya it works really well, and I think in Nigeria with MTN it works really well. So maybe just something to consider. It might help patients consume your content with no charges to them.
Yeah, thank you very much. Yeah.
Was going in a similar direction. You showed the cost structure. Is it right? So is it $1.50 to use it, or is it a monthly fee, annual fee? And can you just explain a little bit?
For subscription?
Yeah.
Okay, thank you very much. Just for subscription for our e-learning platform, people can enroll for you can say in dollar is $5 per month. But also, as I mentioned, we are working with those governmental and non-governmental organizations. Like, if I can say, like one who Save the Children we are working with, paid for some schools. And then for those schools, they use our e-learning material for them. So they're like beneficiaries, those students who are in the schools. But for person, it's $5 per month. Thank you.
Thank you so much, Mr. Jerome, for the presentation.
Yeah.
You've mentioned something very interesting in your presentation, that 44% of the deaths in Rwanda are CDS.
NCDs.
Yeah. And then, so I wanted to ask if you do have any special research that you are conducting on the non-communicable diseases, especially diabetes or cervical cancer. Because I'm on my research, and I would like to know if you have any endeavors that you are working on it, so that I can follow up with you.
That's working on it?
Yeah.
Okay, thank you very much. But for us, as we heard from the morning, the piece from Livestream, they say that also they're working on screening and NCDs, a part of NCDs. They are screening and also taking if I can say, the measurement for those people. And those who are in the red line, I hope that they also give advice, whatever they can do. And for breast cancer, I'm not sure.
It was not a breast cancer, it was cervical cancer and diabetes. Diabetes type 1 and type B.
You mean like a startup working on it?
No, it was a campaign that we've started with someone in Milan, and so we're working as a group. And then I wanted to learn if you have any sort of research that you're working on on those two specific diseases, so that I can follow up with you.
Okay, yeah. Thank you. For diabetes mellitus, we can work together because also we are working on it. For those NCDs, we're conducting researches. But also for the cervical cancer, maybe I can link you with some other people working on those projects. They conducted researches on about that. After this, I can give you the link of them, and then we may keep in touch. Yeah. Thank you.
And one more question, and that is in regard to showing impact of the educational activities that you're doing through your system. Did you already give it a thought how you would measure and then demonstrate impact? Because once you were able to show that you have less childhood pregnancies, etc., that may increase the uptake.
Yeah, thank you very much for the good question. So for us, measuring the impact, that's the reason why we've decided to conduct researches. Yeah, because as I mentioned, in medicine, whatever we do is evidence-based. Nothing from our mind we can present also say. So whatever, about the numbers, also we have, according to the recent data, we have seen also there is still increase of teenage pregnancies, up to 15%, yeah, from 2021. So for us, we want to see if there is, together with our strong partner UNFPA through Imbuto Foundation, we are also preparing to conduct their research so that we can see if there is an impact about whatever we are doing, because UNFPA is also supporting us, and also they want to see if they are also doing some impact. So even for us, we see also whatever we are doing, if it's impactful to our community. But after that, we are receiving many feedback from our clients from the school we are working with, because they're giving us some schools, they were having an increase of teenage pregnancies, but after using our content, they told us that there is an improvement after that. So by that also we can measure that impact, but also we conduct research so that we give you numbers. Yeah, thank you.
Thank you so much. A round of applause for Dr. Jerome. We're now going to hear from David Chen, co-founder and CEO of Capsule, with a background in genetics, and he has over 6 years of pharmaceutical consulting experience. David is helping Capsule to revolutionize African healthcare by collecting, aggregating, and standardizing data from various markets. So, David, over to you. All the best.
All right. Well, firstly, thank you for the introduction, and it's a real pleasure to be here today. So, I'm David, one of the co-founders of Capsule, and we are unlocking the power of healthcare data. And through this presentation, I'll show you both how and why. So the problem that we're solving is that pharmaceutical companies, NGOs, and government lack a centralized source for reliable healthcare and patient data. But why is this important? There are a number of potential use cases for this data. Firstly, it can help boost pharmaceutical sales by providing in-depth analysis of particular markets. Secondly, it can increase clinical trial capacity by highlighting patients as well as potential sites that can run the trials. It can help evaluate new drug efficacy by monitoring the performance of a drug during a trial process. And it can guide healthcare access strategies and identify areas that would have the most impact for NGOs. But I'll take you through an example of why healthcare data is powerful and talk you through a real-life example that is relevant to here in Rwanda. So some of you may know that Gilead were developing a number of years ago a very potentially groundbreaking treatment for hepatitis C, a new antiretroviral treatment. But for them, they were having a particular challenge. Where do I find the patients and where do I find the sites to run these trials? Meanwhile, here in Rwanda, it was known by the health ministry that there was a significant number of the population that was suffering with this disease, 3% at the time. And they also knew that they had the capabilities to run the trial because of the processes that they've implemented when it comes to capturing and managing healthcare data. So due to a mixture of the effective management of the disease information and data by the Health Ministry and the proactive leadership of the Ministry of Health under the government, they were actually able to approach Gilead Pharmaceuticals based out in California and have them used for the sites and the trials. Unfortunately, the drug was a huge success. The early clinical data was very successful, and the drug later got approved, which set the path for Rwanda eliminating hepatitis C as one of their major priorities. Some of the successes of that campaign was the disease prevalence went from 3% in 2015 to 0.35% in 2022, and the country is on course for their elimination goals. So what did we learn from all of this? We learned that with the right data, we can close the supply-demand gaps in Africa. And that's whether it's looking for novel treatments to treat diseases that are prevalent here, or if it's looking for patients that exist on the continent, or finding sites which are able to run the trials. If you have the right data, you can bring that innovation to Africa. So Capsule is bringing this concept into the 21st century. So you're no longer reliant on proactive government to do this. We're creating a one-stop shop for healthcare data in Africa, where all of this information is easily accessible to both industry and to the government. And we do this by pooling data from a mixture of insurers, hospitals, clinics, pharmacies, as well as EHR and ERP software. And this allows our clients to make data-driven decisions. And our business model is very simple. We aggregate the data and we collect the data, and then we commercialize the data. And the reason, the ways we're able to collect the data is in three ways. The first way is we actually provide analytic services to the insurers, hospitals, clinics, and pharmacies that want to understand their own data. The second way is we provide in-house software to digitize a lot of the manual processes that happen in different facilities. And the third way is by having commercial agreements and partnerships where we have revenue shares with entities that have significant amounts of data, where we offer very transparent terms and have a 50-50 relationship with those data partners. So we're incentivizing them to make use of their data in the right way. Now, why do clients work with us? Well, we actually help them to analyze the demand for particular drugs, to identify potential sites for clinical trials, identify patients which are eligible for clinical trials based on certain eligibility criteria, and finally, we can help them extract real-world data to see how a health system is performing. So in terms of Capsule, we're validated in post-revenue. We have a number of partners across the healthcare space in the hundreds, giving us access to over 14 million patient records. From that, we've also gotten 4 software partnerships where we're working with them, and we've deployed our approach in 6 countries which we're collecting data from at the moment. And we've also been approached by a large Fortune 500 company who is interested in acquisition, which further validates our approach to going to market. Why were they interested? Well, this market is growing at breakneck speeds. It already stands at a $44 billion market, growing 10% annually, and also a significant opportunity in Africa, because as Africa spends disproportionately more of their GDP on medicines while simultaneously contributing the least to clinical development at just 1 to 3%, depending on the metric that you're looking at. So in terms of what we've done so far, we've had a number of significant wins this year, but I'll highlight some of the main ones. Earlier on this year, we processed 500,000 patient records. We hit break even as a startup, which was a huge milestone for us. We also secured multiple clients who are Fortune 500 companies. As for the rest of the year, we want to close it out strong, and we have a number of targets. We want to process 20 million patient records. We want to be EBITDA positive by the end of the year, and also expand our approach from 6 to 10 countries. And finally, that's setting us up for a stellar year that we're planning to have next year in 2024, where we want to export our approach to the rest of the world, starting in Latin America. So that will position us to be the leading data provider of not only Africa, but also lower middle income countries. And there's a number of reasons for this. The first one is we've already secured partnerships with the data buyers. We know precisely what type of data they want in the format that they want, and that enables us to go and build these partnerships with the different data partners. Secondly, we've built an innovative way to be able to aggregate and interpret data from various different formats and sources. And that enables us to do comprehensive analytics regardless of the source of the data. And then finally, we have a very transparent business model where we want everyone to benefit financially from collaborating with Capsule. And we see the days of big tech long behind us where they monopolize data at everyone else's expense. We want this to be a more sustainable and inclusive business environment for the data market. So as for the team, we have extensive experience. This is just the leadership team. We have many more supporting us, but we have a wealth of experience in the healthcare space as well as technology and the pharmaceutical industry. And we couldn't have got here without the number of partners and investors and backers that we've had along the way. And some of them include some of the largest institutions across the world. So our ask is a little bit different. We want to speak with investors who have specific experience in the healthcare space and those with a large health tech portfolio company, because we believe that not only is there a potential to invest in us, we can also add value to your portfolio companies by helping them commercialize their data. Secondly, we'd like to talk to any healthcare facilities that is gathering large amounts of data because we can unlock the value for you. And finally, if there is any organization that require data, please speak to us because I'm sure we can help you. Thank you.
Time for questions. Okay, we have a hand on the other side. They're going to get you the microphone.
Hey, that was an awesome presentation. Really interested in what you guys do. I have a question about data quality, because I think in institutions that I've seen, healthcare data on a patient can range from having their phone number to having very detailed, longitudinal, structured data sets about their clinical condition. How do you think about data quality in this market?
That's a brilliant question, and that is actually something we ended up iterating to in terms of how we approach data quality now. So what we actually found was, to your point, data is highly variable, but where we found it was consistently well managed was in the private sector. Because what we realized is private institutions, such as private hospitals and private clinic groups, they're incentivized to actually use their data to drive their business. So when we were actually looking into their data, we found it was much more consistent, much more structured, and that was much easier to work with. We've now expanded into partnerships which include NGO clients. Again, there is a variable data, but what we've found is that we can often calculate the missing data based on what we've learned in the private sector and applying some of those learnings to the incomplete data that we're using in the NGO space. Our assumption is once we get good at doing that both in the private sector and in the NGO space, we can then apply those learnings to the public sector where the data generally tends to be of lower quality.
Hello, thank you so much for your presentation. I enjoyed it thoroughly also. So I'm Felix from Black Pearl. I have a quick question about data privacy, sort of with what he asked, healthcare data, and also with regulatory requirements. Are you able to get data from any country easily? Are there some requirements you have to fulfill and so forth?
Yeah, so another brilliant question. And data privacy is at the very core of our business. So we actually consulted with some of the regulators before we built anything, just to find out the best way to do that. So for us at Capsule, we actually only collect the aggregate data from our clients. And the way that we integrate with them is that we're only querying the aggregate data. So we only see numbers or answers to a specific question. So no individual patient data is compromised at that point. Even though that's the case, in our business model, we don't touch the patient data, we have already gone in and applied for the relevant licenses, both as a data controller and data processor, because we knew that if our business eventually goes into touching the healthcare data, we would need that provisions. As for how we... Sorry? In terms of the countries that we're working in, it's South Africa, Zimbabwe. We also have operations here, and we're collecting data from Uganda, Ghana, Uganda and Kenya as well, with view to expand into other markets like Egypt, Nigeria, Ghana. Any other questions? There's one at the front.
Also, congrats, great presentation. Actually wanted to build on a question from Rob on longitudinal data. So I understand you're collecting aggregated data. Does that mean it makes it a bit impossible to actually follow a patient through and look at the evolution of the patient outcomes?
Yeah, so in terms of the data that Capsule would immediately have access to, that would be difficult. But due to the nature of the relationships that we have with our data partner, we can actually send them requests to follow specific patients. So they are having and managing the relationship with the patient directly. They already have the patient consents, and they would be able to send that if the patient agrees to share that data. So that's why we had the partnership as a very important part of our business model. So in the event we wanted to follow cradle to grave a patient, we would be able to do that through our relationships with our data partners.
Hi, I have one small question. How do you process the data? Because it comes different depending on the source. How big is your team? That's my question.
So fortunately, we have a wizard of a CTO who has a lot of experience with dealing with harmonizing data from many different formats. So we use a lot of the cloud providers. So in terms of the process, what we do is the first step is we standardize the data. So we've already done the topology of different data sets to look at what is usually included in, say, pharmacy data, hospital data, and so on. We mapped it out, and then we tried to effectively bridge that to our own data lake, as we call it. And then from our data lake, we do the analytics. And then from the analytics we get from the data lake, we provide to clients. So we have many different inputs coming in, standardizing it all. We then analyze it, and then we push it to our clients.
Thank you so much, David Chen. A round of applause. Time is up, and we are halfway through the 6 speeches so far, 3 down and 3 more to go. We're now going to hear from Gel Schutmaker, co-founder and CMO, Goal 3. A round of applause as Gel goes to the podium. He is a seasoned entrepreneur active in health tech innovations for low and middle income countries. In his studies and early career, he co-founded Goal 3, a global social enterprise with a strong mission to enable health workers with data-driven tools to improve the quality of care, save lives, time, and cost. Over to you.
Yes. Hello, good afternoon. I thought it's better walking. So my name is Jelle, and today I want to share our story of Goal 3 and how we make data-driven solutions for hospitals in low-resource settings. And this morning, my colleague and I were at Nyamata Hospital, a hospital it's across around 1 hour drive from Kigali. And we started interacting with them already 1 year ago on what we do. And I wanted to start with the question, who here has visited a hospital in Africa before? Okay, it's good to see some hands. And maybe a difficult question, who here visited a neonatal ICU? So an ICU for premature babies in Africa. Okay, a little less hands, but interesting. So we visited this neonatal ICU of Nyamata Hospital multiple times. And first of all, I want to say I'm very impressed by the healthcare workers that work there every day. They are under a lot of pressure, and they're doing the best that they can do with the resources they have. But unfortunately, and if we look to this data of such a hospital, and if we extrapolate that across the continent, more than 3 million children die needlessly every year out of the following problems existing in these hospitals. Up to 70% of medical equipment is not working. So can you imagine if you have a premature baby, but you have no ventilator, or you don't know where the oxygen is coming from? And there's also 10 times less healthcare workers in most of these hospitals compared to other settings where a nurse-to-patient ratio is often 1 nurse over 20 patients, while maybe in the Netherlands, where I'm from, it's 1 nurse over 1 or 2 patients. So can you imagine how hard it is to really do the work you want to do in these settings? And if we dive deeper into this problem, you see that mortality rates increases for every hour that you're late in making the right diagnosis. So it's very important in this under-pressured setting to still be able to make the right diagnosis. And that's what we started working on. And what we are actually doing as a company is we provide nurses and doctors with tools to get them from reactive to proactive care to save life, time, and cost. And it's maybe a bit difficult to see, but if you're a nurse in such a setting, these are the patients you're managing, and you're checking all the vital signs of these patients constantly. And this is not a very efficient process, unfortunately. So what we are doing is we're providing them with tools to walk a more efficient way through their work. And now, of course, the question is, how do you do this? So this is what we built, the Impala system, named after the safari animal Impala, where on the left you see a patient monitor that monitors vital signs of patients that is designed for these settings. So it's robust, durable, easy to use, easy to understand. And these patient monitors, we connect them to these tablet applications. And on these tablet applications, we support hospitals in patient management. How is the patient flow in my hospital? Which patients are coming in? But also help healthcare workers to make prioritization in these patients. So you can see on the red, the most critical patients are colored red, and yellow is a medium critical patient. And through doing this, first of all, we support the clinical care, which is really important when you bring an innovation into such an overburdened setting. If it's not adding value to your clinical care, it will never work. And second of all, we're also capturing the data behind this process to help them to optimize this. So after a month, often hospitals that work with us, they can do a review of the month. Which patient did we have in our ward, and how could we manage them better in the future, creating a cycle of quality improvement in these hospitals. So here is a bit more details on our Impala application. So you see a multi-patient overview where all the vital signs of the patient are displayed in a very intuitive way with something what we call the patient avatar. And behind this is all the statistics of a patient over the last 7 days, when their vital signs went out of range and how their vital signs are progressing to support also this quality improvement cycle. And today I want to share some results from one of the first hospitals that we implemented outside a research setting. Because in a research setting, we have very easy results because you add a lot of research nurses and staff to this setting, which makes it easier to gain a positive impact. But in this setting, no extra research nurses were added. It's just training and implementation of technology. And what we achieved is that pediatric mortality dropped with 60% over the course of 6 months, and the admission times went down with 16%. And these admission times are very important to get this solution cost effective, because these are ICU beds, and every half day you can save with this intervention can save a lot of cost to the hospital. So if you calculate this through the cost that we're currently charging, the cost per life year saved is around $5, and the earn-back time is less than 2 years. And if you go to global health interventions, this is more cost-effective than malaria mosquito nets, for example. So this is really cost-effective. Of course, this is still early-stage data, and we're working here in Rwanda also to get better data on this intervention. But this is very promising, and this is why we really believe that we're on something big here. And the thing why I started with Nyamata Hospital is very comparable to this hospital. And I lived in Rwanda for the last year, and I wouldn't be more happy if we can see these results here in Rwanda as well. So that's what we're doing now, and that's why we're working here. So how does this work in a business model? Currently, we see that hospitals often do not have the capital expenditure, so the buying power to purchase this equipment. So what we're currently doing is we work together with some implementing NGOs and some partners, GIZ and ECPAF are some of them, to purchase equipment for hospitals. And we connect to the hospitals and get a subscription model to them, because it's very important that there's local commitment on these systems, but also that there is a service and maintenance contract and that consumables and sensors can be delivered. And this creates a flywheel of more and more growing installations, where we're trying to grow to 10 hospitals in this year and 30 hospitals over the course of the next year. And of course, if we can duplicate these impact results in all these hospitals, this will have a huge impact on child mortality numbers. So this is our leadership team. I'm here with my colleague Patrick, who is still awake. And we're working with a lot of big partners here in Africa to make this work and to bring this at the right places where it's needed. And today I want to round off with our mission. We want to improve the quality of care for 100 million patients by 2030. And to get there, we need investors, we need NGOs, foundations, and governments that want to support us in implementing this. And we want African hospitals and healthcare professionals that are eager to embrace innovation and test with us. So that's our story, and I hope you all want to join us on our journey to our 100 million quality improvement of patients by 2030. Thank you.
Hello, Joe. Hello, Joe. Thanks so much for your presentation. 2 questions or 3 questions. So first, I want to understand the business model. If you don't mind sharing, how much does it cost to get a device? And what's the subscription, price? Is it per month? And how much you charge to the hospitals? And the second question is, I know you mentioned it's a social enterprise. I'm wondering, is it, I work with a VC firm, so I'm a bit lost. Are you looking for grants? Are you looking for, VC funding? What is the goal here? And if profit is not a goal, then, it's fine. I just want to know.
Yes, thank you for the questions. So first of all, the cost of the business model. So patient monitoring equipment, you can go very low cost to Chinese equipment, which is often between $500 and $1,000. And then there's very high-end equipment, Philips, Siemens, these kind of brands, often $2,000 plus per monitor. We're somewhere in the middle of that. We cannot compete with the Chinese systems yet. And we want to make sure we deliver quality in our system, so around $1,500 per system. And the subscription model is based on a fee that is very hard to calculate. So you have to calculate per hospital, but it basically depends on how many sensors you supply, how often you do your maintenance checks, and how often, how many monitors they have a subscription for. But it ranges between $1,000 per hospital to $10,000 per hospital. So it really depends on the size. No, per year. Yeah, per month won't be possible here. So then also to your second question, so why could this be a VC case, and is this like a scalable company? So we are for profit, but we say for profit. Profit is a means to create more impact. That makes us a social enterprise from that perspective. What we are building is a patient data management solution that gets the most detailed data of what is happening to patients inside a health facility from when they get to the door to when they are referred. And if we can do this in hospitals first, we can also do this in health centers, and we can do this in health posts. So if you hear all the other companies talking about data, how do you get reliable data without being on the ground in these hospitals? You need solutions like ours. So that makes it a VC case in the future, you would say. But for us, as I said, profit is a means to create more impact. So we would only use this if it's relevant to the patients and to the problem that we're solving.
So my That's a brilliant solution you have there, very brilliant. Now, I want to know how you manage the uptime. Maybe you've answered, but I need to know how you manage the uptime, considering that we are in Africa, we have power downtimes, and someone's life depends on this.
Yeah, that's a good question. So the reason we designed our patient monitor ourselves is also to make sure it's very robust and easy to use here in Africa. Means it has a long battery life. We put a UPS in between, so when there are power fluctuations, the device is not harmed. So this creates already a higher uptime than most of the other systems. But we do work with local distributors who check with their maintenance teams every once in a while. Also, are all the sensors functioning? Is everything running correctly? Plus, we also train local technicians at hospitals on how do you service this equipment and how do you notify us on time when you think something is broken. Because often that's also one of the problems, that the manufacturer is not notified that something is broken, but people will either try to fix it themselves or stop using it at all. Did we have a situation where everything shut down? No, not yet. So even the hospital I shared in Malawi, it was over-flooded with the floodings that were happening in Malawi in the beginning of the year. So what they did is they didn't get many patients in their neonatal wards, and all our monitors had long battery life. So they even changed these monitors and took them to some of the adult ICUs where they had a lot of patient flow coming. So I could say we're one of the most robust solutions that is out there. But of course, there will be situations where even our technology stops working. Any other questions? Nope.
Thank you so much, Jel. A round of applause.
Last promo. Here is our device, and we will be at the exhibition ground if you would like to see it.
We're now going to get the presentation from William Mafam, co-founder and CEO, Vula Mobile. He founded Vula to connect health worker professions, and his personal experience as the vice chair of the Rural Doctors Association and later as a specialist helped form the solution. He has published academic articles on the role of innovation and technology in improving healthcare delivery. A round of applause as he takes the podium.
Hello, it's me again. Dr. Will Mapham from the Eastern Cape in South Africa, and I hope this works. Turn mine on again. Let's try. Otherwise, you'll have to change it. But yeah, I guess I can tell you some more stories while we wait. There we go. So my passion is improving healthcare in rural areas. If you give me a chance, I'll go as far away from Kigali as possible. I really love seeing where people actually work, live, and where you can make a difference. So I'm from the Eastern Cape. Let's try again. There we go. So this is where I used to work. This is Madwaleni Hospital. And we used to say it's just to the right of the middle of nowhere. But the hospital there served 250,000 people. So we were really busy having to do everything ourselves. If you came in the door, we had to help you. And we really did our best. But as I said before, it's a real challenge. In South Africa, our biggest province is the Northern Cape. And how many of you would drive 7 hours to see a doctor? I think it's actually closer to fly to Europe from here than to go and see a doctor. So basically, access to specialist care is impossible for most people. I mentioned earlier that I wrote a referral letter to a specialist. This is it. This is the letter that I wrote in 2004 so that the patient could go and see a specialist in Mthatha. And although it was only 3 hours away, I really thought that he would go and see the specialist. And as I mentioned earlier, when I went back 7 years later, he came with the same letter. That's how I got the photograph. He had gone blind in that eye because I hadn't treated him properly. And as a specialist, I realized that we could have treated him the first time I'd seen him if I'd just been able to give myself some advice, because we even had the medication he needed the first time I had seen him. So this is kind of a case that haunts me. And if you speak to any healthcare worker, they'll speak of the ghosts of patients past that really drive you to do some of the things that you want to do. This is a picture of the back of my head. I'm specializing at Tygerberg Hospital. You'll see I'm seeing patients, I'm teaching students, there are more patients waiting, and that's the phone in the corner that just rings. And I promise you, if you go into any health facility here, you'll hear a phone just ringing. And so we had to solve the problem both for the rural healthcare worker and for the specialist. So Vula comes from Vula Mehlo, which means open your eyes, and Xhosa, Siswati, isiZulu, a lot of the languages we speak in South Africa. And the Vula Mehlo Eye Clinic is actually in Swaziland. It's about the size of this section of the room, so it's very small, but it's a paperless clinic. It's got a double-sided theatre. It's very efficient, so if you want to see a great eye care clinic, go to Swaziland. And I think what I learned there from the surgeon wasn't just surgery, it was about how systems can actually change lives. And when we visited some of the rural healthcare workers, they had better phones than me. So I think sometimes there's a fallacy that rural healthcare workers don't like phones. In our experience, they do. And often they're better than the specialist phones. So we already had to max out that opportunity. And yeah, it's an app that any healthcare worker can download. They register, they're vetted. So all the healthcare workers on Vula are certified healthcare workers. And then they choose the specialty they want to refer to or the hospital. It connects them directly to the specialist on call right now. And that saved that doctor or that nurse about 45 minutes of trying to phone around, trying to find out who is on call. But beyond that, every specialty has a unique form, so we've customized it for all the different specialties, which means that when the specialist gets the information, it's quick and easy to see what to do, and then he or she can reply between his or her own patients, and then the patient essentially gets specialist-guided healthcare at a primary setting. You've saved the healthcare worker time and money, you've saved the healthcare worker time, the specialist time, and the patient's travel money as well. There was a lot of talk yesterday about doctors being hard to work with, and so I definitely recommend that you do work with healthcare workers because it's a very small eye in the needle to go through. So we spent a lot of time working with healthcare workers trying to get things right. And so this is us doing a lot of user experience research, getting them to test things. But if you do get it right, they will tell everyone else to use it too. And this quote's actually from the Department of Health. I wish I'd written it myself, but the Department of Health calls Vula the glue that holds the health system together and the oil that helps it work efficiently. We started off in ophthalmology, then other specialties wanted to use Vula. We only go where we asked. It's now used in 75 different specialties. We're getting more every day, which is quite interesting, more and more requests. And so, yeah, what they also asked for then is, can we talk to each other? So now the orthopedic surgeons could add the physios, and they can add the occupational therapists. And now you've got kind of a community of care around the patient. Although we found it in South Africa, we have expanded. It's been very exciting. I've been to Navronga in northern Ghana, thanks to Novartis. I've been to Gondar in Ethiopia, which was a real life-changing experience. I can see a nod there, probably from Ethiopia. Incredible place. And we've got also in Botswana and Namibia as well. So we're kind of learning about other countries, and it's fascinating to hear about other countries being accessed, because everyone's very different. So it's a real challenge. We've been growing for some time. This is the figures up to date from end of last year. We're over 32,000 healthcare workers already, and we've gone over 1 million patients in total, and we're aiming for 500,000 patients in this year alone. And that's the good news. But the hard news is, if you look at the beginning, it took us 2 years to get any kind of traction. So if you are a startup, just keep trucking, because you do need to have a lot of experimentation before people start using you. We talked a lot about compliance. What we recommend is, don't just be compliant, tell everyone that you are compliant. So if you go to our website, all our compliance documents are there. If you go to the bottom, it says legal compliance. You can copy them, use them, or adjust them to your local setting. And I've got our compliance officer to publish on the way we use apps and data. So it's really useful if you are an academic or if you're linked to academic people, make sure they publish on your approach. There have now been about 20 publications on Vrula. We haven't done any of them. Because if you think about it, all the academics need to publish. And what do academics need? They need data. So go to your local university, which was what we did, and said, here's all the data, please publish something. And so they did. And so what they found in sort of summary is that patients, if they are referred earlier, have better long-term outcomes. And healthcare workers who are making referrals, every time they make a referral, they learn something. So they're being upskilled without having to go away for training. And you reduce the number of referrals having to travel those 7 hours at a time to see a specialist by 30% on average. The highest was 52% in obstetrics and gynecology, which we didn't expect. So sometimes the things you find out aren't what you expect. But the nurses were so nervous, they were sending all the patients through, whereas just a bit of reassurance, the patients could stay where we were. You asked us to brag, so I'm going to brag on behalf of my team. But the UNDP did rate Vrula as one of the 4 most innovative solutions globally improving access to healthcare. And thanks, we're going to take this back to the team. Sorry? Yes, and then in Concordia Summit in New York, wasn't that long ago, a few weeks ago, the HealthTech Hub won an award for being the best public-private partnership. We are one of the HealthTech Hub scale-ups, and we came on stage just after that to talk about our work with rare diseases, so it was very good timing. In terms of what we're looking for, you can't save the world with AI if you don't have data, and as you mentioned, quality of data is exceptionally important. And most health records in Africa are still on paper, so essentially we are digitally invisible. And so when Vrula is used case by case, suddenly cases do become digitized and you do have the opportunity to create diverse data sets from developing countries that can then be used to educate international technologies like AI. And you talked about quality. So when the healthcare workers use Vrula, they're talking to each other. And because they're getting an instant response, the quality is very high. So it's an unusual case where in a public sector hospital, you're actually getting quality data, which is very interesting. In terms of what we want, if you've got any interest in AI, health data, you want to do research, or you want to create tools that will make a difference, that's one of the things we are looking for from this audience. The other way we make revenue, it took us a long time to work out how to make revenue with this model, but there's a lovely quote from the NHS where if you provide value, the money will come. If you want to provide face masks and COVID, you will make a quick buck, but you probably won't provide value in the long term. And so we kind of used that sort of mantra that one day the money will come, and it did take us 4 years to get any kind of revenue. But essentially what we found out was that the people that are incentivized to make the public healthcare systems work in Africa and developing countries are the pharma companies. If you went to hospital and you didn't give medication, you wouldn't think that's a very good hospital. So all healthcare depends on some form of treatment or surgery. So we partnered with Novartis to improve ophthalmology systems in Namibia, Botswana, for sickle cell in northern Ghana, with Jepaigo for obstetrics in Gondar in northern Ethiopia. Sanofi, we worked with them. We won the Vivitech Prize back in 2018. We didn't have psychiatry, endocrinology, or tuberculosis on Vrula at the time. They paid for us to launch those specialties in conjunction with some of the departments in South Africa. And we've now got a long-term contract with them, and they're looking to expand into Zambia. So there are companies out there that you can have contracts with that can actually help you generate revenue. So it's been great to, I think last year we had a revenue of about, trying to work out in dollars, it was about 500,000 US dollars, and we're now up to 750, 2/3 of the way through our financial year. And so we've had our millionth patient. Here's a picture of our team. We talked about gender equity, I think, a bit earlier. Very proud to say that we focused on that. Our team is more female than male, which is unusual for a tech company, and very proud to have that in place, and hopefully that will last a long time. And as you can see, our logo is African beads being drawn together, and one of the reasons we've come here to the HealthTech Hub is to connect with other people. So looking forward to connecting with you all over the next couple of days. Thank you.
Thank you, William. We have less than 2 minutes left. Maybe we could get maybe a question. Kindly do tell us your name and the institution you're with, and keep it short.
Hi, I'm Rubai. Hi, I'm Rubaiyat from Endless Network. It's a family foundation based in the US. I was just wondering if you're using any sort of algorithms or AI to help the health workers make better triage and referral decisions. Thank you.
The answer is not yet. So we do have a lot of data and a lot of records. We are working with Google on their dermatology AI, but we don't do it currently ourselves. And it is something we'd like to do. So one of the pitches that we would like to have is to companies that want to create data-driven solutions for Africa. And we can develop those tools because we've got the data, we've got the use case, we've got the users. We just need that missing layer of doing the hard work. Yeah.
Any other question? Thank you so much, William. Our last speech for today, we have Brian Senonga, founder and executive director, Guild Digital Solutions. Oh, there he is. A round of applause for Brian. He has over 15 years illustrious career. Brian is a transformative force in technology, leadership, and development. And as the founder of Guild Digital, his work in digital health spans from West, East, and Southern Africa. Brian, over to you.
This is the PDF, but the slides should be there as well. So, as we wait for those to come up, let me get you all on a journey to build a health system with me for refugees in Africa. And so, there's about 89 million refugees in the world, and many of those are in Africa. I come from Uganda, and it should not really be a proud badge to wear, but we do host one of the largest refugee populations on the continent, about 1.5 million of them. When refugees show up at your door as a country, they show up into a reception center. There'll be a team from IOM or UNHCR or UNICEF or some other agency that will process them. Some of them will go back home. Some will be resettled in a camp. For most countries, they go one step further. They'll create very elaborate spaces called settlements, where some refugees will get a long-term opportunity to actually live side by side with a host community. And that's the definition of a refugee settlement. In the settlement, if you're a refugee, you have an opportunity to rebuild your life, to send your kids to school, to attend the nearest hospital. If you're not in a settlement, hopefully you have been repatriated out of the country, or you are on your way back home. And the circumstances that made you a refugee in the first place may not be solved. But that's the people that we want to support. So, for those families that make it into a refugee settlement, they have the opportunity to access the services. And now, the governments that support this work, Rwanda, Uganda, Mali, and all of our neighbors that deal with this situation, the question is, will you offer a different type of health care from what you offer citizens? Will that make you a good host of refugees? Actually, you will offer the same quality. And so, how do you take a refugee settlement that's got 7 different nationalities, that speaks 5 different languages, and provide them the same quality of care, following the same guidelines and policies as your host community, which will largely be a very homogeneous community. One district, same language, can even operate using a local dialect and not English. Most importantly, how do you do that without breaking the guidelines of the national health system of the host country. And that's what we're trying to do. So people like Bonway have lived in 4 different locations, and he's only 27. He's had the opportunity to come and live in a settlement. And even though he's lost his dream to become a teacher, he's now made a choice to become a community health worker in Chaka refugee settlement in Chegegwa. We call him Papa because he has such a big heart. He trains all the other community health workers on how to do the same work that he does. Settlements are not your typical spaces. They're not your regular suburban community area. And so you have to figure out how to make this thing work. Most settlements are not just on the outskirts of the capital. They're in little remote locations right close to the border. So they actually remain hard to reach areas, and they're not very easy to work in for health workers or indeed for the people who support them. The only way you operate healthcare that works in such settings is to go door to door. So community health workers are the backbone of healthcare in places where structures are poor or unsustainable. If you can't pull it off with them, it's very hard. The question that Guild Digital is trying to solve is, are we convinced and can we build a solution where digitized refugees, retrained and supported in new settlements can serve fellow refugees with healthcare? And that's what we want to share with you. So in building this system together, we have discovered that we want a very strong healthcare system, very clear guidelines, and so we need to work with the government in place. We know that we want commitment, healthcare that's going to be longitudinal and that's going to stay in place. We also know that to manage refugees is a very political scenario. So you have actors like the government and UNHCR, and you have the people who help them, Oxfam, Save the Children, MTI, and the likes. And you need all those people as part of your ecosystem. And then digitization, based on digital public goods, because we want to make sure that the product and the solution that we're bringing is really cost effective and easy to adopt. And so you take all of this ecosystem and you put a cherry on top, and you call that a digital partner, to begin to work with all of these people to build a platform that works for the refugee settlement. And what you get is an Android application that's offline first, that's mobile, that provides for longitudinal care, supports the community health workers to treat multiple areas, and in doing that, you cover a lot of areas. You do that, and you support them with an online dashboard, helps to bring analytics to life, supports decision making, and then you make sure that you learn how to stitch the whole ecosystem together. Your digital partner, your health implementing partner, your government partner, and all of the guidelines that tie healthcare together while preserving protection and privacy of refugees and settlements. This is typically what community health looks like. You have people right at the lower level that are supporting the healthcare system, and then you have health program assistants that provide the work, and then you have health system managers at the top. And when you take that system and you digitize it, you begin to apply technology that's appropriate for a certain level, because different people will need different solutions and different tools in order to work and do this well. But healthcare is about the challenges, the real ones: child health, maternal health, water and sanitation hygiene. These are still real challenges. We need to find a way to still solve them. And your model is community healthcare. And so how do we make this come to life? What we've done is to work with Medic, who is the technical steward for the Community Health Toolkit, which is a digital public good. And so that lowers significantly our cost of production. And so we've got an app that does longitudinal contacts, schedules, and tasks for the VHTs to remember which household to go to. It will provide them with daily schedules. It will do analytics. And all of this is tied into a data model that starts with analytics on the mobile and continues all the way to dashboards on a bigger web-based system. And the data is managed in standard platforms. Part of it is AWS. And we're using standard open source platforms that make interoperability very possible. So when you're delivering software as a service in such settings, you create a number of tools. The first one we did was a training platform so that all of the settlement partners can learn without interrupting any of the production data. You've got your production platform. We use Clipfolio for our analytics. And of course, the app, together with UNHCR, is in the Play Store. And so this allows for very seamless and quick scale should you be moving to the next location. The VHTs, the refugees themselves, have an Android tablet. They also get a power bank, nice, beautiful one, works with solar, has some lights, multi-purpose tool. So it allows them to really take ownership of this toolkit as part of their device set. And what have we managed to do so far? Uganda has 13 settlements. We're in 3 of those right now. We've managed to work with 702 VHTs. We measure the engagement rate of 83% by asking how many healthcare actions were completed this week by a VHT on the device. And so that helps us to really see, are people using the tool? We have to work with many organizations, 6 of them in the settlements, and supervision involves the public health assistance. Supervision is a key pillar in a successful community health program. You need it. So there's more than 1.5 million refugees. And we think that there's a real chance because our biggest partner, UNHCR, has committed to scaling this to all the 13. But we still have a lot of work to do. We asked the VHTs, does this work for you? Do you feel like this makes sense, even though it is very different to what you're used to? And so we found some things that they said, we can't fix this in the app. It's giving us a hard time. We've not been trained well enough. And they go to their fellow VHTs for help. And we found some things that they can't fix, and they go to their supervisors for help. And this has already showed us and validated our commitment to build supervision as a pillar. But we also took a University of Washington tool, the system usability study, and we asked VHTs about the sentiment of the app. How do you really feel about the app? I feel like I can use the app every day or all the time. All of these statements is feedback that's coming directly from users who've been using this for just over 6 months. Supervision is something we're looking forward to. Medic is committed to the CHT, and we're in line with them. And most importantly, we're ready for interoperability. This is how we're looking forward. They've also told us, we really want to learn this. It's important, it's useful. And so we have some program objectives that we're looking forward to. We recognize that as a health tech startup, we're working in a large ecosystem. And so our program goals exceed just what we do as an organization. It's really the partners. And we're looking forward to some of you joining some of these in our partner ecosystem. This is how you would think you can partner with us and some of the work that we're already doing. It's very exciting to be here and to share with you, but effectively, this is how we'll grow. And we've been able to make it to this place because of the kind support and work of these people. and of course the HealthTech Hub that we're part of. Thank you very much.
Thank you so much, Brian. Maybe we'll have time for only one question, if there's someone who has a question. Okay, we have... Tell us your name, the institution you're with, and kindly keep it short.
Thank you, Mr. Mugenyi Edgar. My name is Napoleon. I'm a content creator. I have a platform, it's called Tech Magazine. So do you have data for refugee complaint about if it's been satisfied or if it's not been satisfied about the service? Thank you.
Yes, so we do conduct user feedback surveys periodically to hear directly from the VHTs that are using this. And while we don't work directly to manage the political and administrative structure of a refugee settlement, we're plugged in with the health partners, and so we're able to track that feedback and send it upwards for administrative support.
Thank you so much, Brian. A round of applause. And this wraps up today's pitching session. We've heard from 6 incredible startups, and also I'd like to mention that tomorrow we'll also hear from more amazing startups. So hope to see you all here tomorrow afternoon as we continue to get to understand some of the innovations that we have within the African continent. For now, we're going to receive the closing remarks for today. I'd like to welcome Dr. Lutz Hedgeman, President, Global Health and Sustainability at Novartis International AG, Switzerland. A round of applause as he comes to the podium.
Thank you very much, Fiona. Ladies and gentlemen, this was an incredibly inspiring day, I must say, for my team who works in global health at Novartis to remove barriers to access to innovative healthcare, and for myself. And I could not do justice to the richness of the content by trying to summarize it. So instead of that, let me just share a few personal reflections and thoughts at the end of this very stimulating day. Let me start by the content itself, which is about digital healthcare, data and digital. And very often in conferences that I attend, these are being used as buzzwords. And I sometimes wonder, well, and so what? And what does that really mean for us day in, day out as we are addressing those barriers to healthcare? And I think today's day, more than many other sessions I've attended, was really filling this with life, with very concrete, very tangible, practical and relevant examples. And I was truly impressed by all of those approaches that I felt had one thing in common, which I find incredibly important in the space in global health that we all work in, and that is putting the problem at the center of what we are doing. And my colleagues here from the leadership team can give a testimony that we very often ask our own teams, what is the problem that we are trying to solve? Because so many times we see entrepreneurs, we see scientists, we see technicians falling so much in love with their solution that they lose sight of the problem they are trying to solve. And this to me came out in very much every presentation today, that there was that eye on the problem, and that to me makes those solutions that we heard of being so incredibly powerful. I think it's true to say that digital healthcare ultimately is a good means to help overcome constraints that we see in resource-poor settings, and that we need to select those targets very carefully. And I think we got excellent examples today on how this can work and how this can happen. So my hope is that as the Innovation Hub goes forward, we'll be able to expand it. We will be able to expand it in terms of the number of partners, in terms of the number of startups, the number of ideas that can have such a fertile ground here in order to exchange, build connections, as we saw throughout the day-to-day. And I know the HealthTech Hub has ambitious targets on reaching more patients. I think it's 3 million already, taking this to 5 million, having more partners and people, which I think, based on today's experience, is certainly ambitious but reachable. The second part I would like to share a few thoughts on is the notion of creating ecosystems. And I think that came out very loud and clear throughout the day, that this is really what we need to do. When I started in global health some 30 years ago, global health was very much philanthropy. It was a donor-recipient relationship between the global north, the global south, or at best it were bilateral collaborations that we were fostering. I think today it's fair to say that we have created ecosystems along multiple dimensions. This Innovation Hub is one of those ecosystems where we bring together stakeholders across the sectors in order to bring the best of solutions possible, their unique skills to the table, connect this with others for a bigger impact. I think we also spoke about the ecosystem that needs to exist in a given country, where it is not just one sector alone, but the partnership with government being so incredibly important. And I met with the Minister of ICT here in Rwanda yesterday, who said we need to be ahead of those developments because we don't want regulations to get in the way of implementation, which I found was incredibly powerful and stimulating, and I wished for more governments to adopt that approach. But then, of course, also the ability to connect the private sector together with NGOs, but also very importantly with the financial sector, is an area that I see hugely underutilized in global health at large. And I'm incredibly inspired that we have a very good round here of representatives from those different partners and sectors who can partner together. Another theme that I believe is important, and again, the HealthTech Hub is a great example, is to overcome the fragmentation that we see on the African continent. We cannot find solutions for 54 individual countries, but we need to pool the opportunity that exists and likewise scale solutions towards making an impact on as many countries and with that as many patients as possible. And I've seen the conversation shifting, which again gives me great encouragement, from sort of what can you do for me, in African leaders now talking about what can we do in order to enable progress. And to me, the creation of the African Medical Agency or the Africa Free Trade Area are just really good examples that could ultimately unlock the potential of this entire continent rather than going country by country, and then we can use the economies of scale that would be so badly needed. We've heard about innovation made in Africa for Africa, which is certainly very nicely lived in this hub here. My personal ambition would even go beyond that. I would like to see innovation created in Africa for the world, because that is another theme that we see in global health, is that challenges that apply to underserved populations in Africa share a lot of similarities with underserved population elsewhere, including in high-income countries like the United States. And I would love to see that reverse engineering, where a great innovation that's being created in Africa for Africa ultimately can be taken at global scale and can expand its benefits way beyond the borders of the continent. I'll stop here because I'm standing between you and your well-deserved reception, but it would be a mistake to not thank at this stage here every one of you who have participated, our startup companies, our investors, but also the Novartis Foundation and Norsken Foundation. Thank you also for hosting us on your beautiful campus, but also all our partners, and last but not least, the organizing and the technical team. When many years ago Anne came to me and presented to me the sort of blueprint of the concept of the HealthTech Innovation Hub, I must say I was a little skeptical whether that would really fly. Now, today is a great testament on the exceptional work that the team, together with the partners and everyone involved, has created, and I just continue to wish the HealthTech Hub every success. With that, I'd like to invite you to the gathering and to the reception. Thanks very much.
Thank you so much, sir. There is really not much that I could add on top of what he had just said. He has perfectly captured the conversations that we've had today, the key elements that have come up. Just reminding you, tomorrow the conversations continue. We'll have day 3. We'll have experts, startups, public, private sector players who will all be here. Networking as well as registration start at 9 a.m. So see you all tomorrow by 9 a.m. here, and let's continue this conversation on tech innovation within the healthcare system here on the African continent. Thank you all. We have, as he said, exhibition as well as a reception. Do enjoy yourselves.
So I've also really enjoyed the sessions this morning from both the clinician as well as the investor perspective, particularly around the challenges in the region for operationalizing and implementing digital solutions, but also on the contrary, what the opportunities are when there is adequate and proper and more coordinated investment in the rollout of digital tools, and where investment should be concentrated. So very much looking forward to the upcoming sessions where we'll hear more concrete examples from people who are actually implementing these solutions on the ground. So I've also really enjoyed the sessions this morning from both the clinician as well as the investor perspective, particularly around the challenges in the region for operationalizing and implementing digital solutions, but also on the contrary, what the opportunities are when there is adequate and proper and more coordinated investment in the rollout of digital tools, and where investment should be